Should we start?
Yes, sir. Start.
Okay. So, good morning to everyone from ICOG FOGSI. This is second Sunday of the month of June 2023, and we are here to have one more ICOG tutorial. This time, our topic is on fibroid uterus, and we will be having two cases on fibroid uterus. Before that, I would like to thank our FOGSI President, Dr. Rishikesh Pai, and our Chairperson, ICOG, Dr. Lakshmi Srikhande, for giving us this opportunity, along with Dr. Ashish Mukhopadhyay and Dr. Hafizur Rahman, to organize this ICOG tutorial every second Sunday of the month. So we are thankful to this FOGSI ICOG team also. And today we have eminent faculty, Dr. Abdullah from Puducherry, Dr. S.R. Sheila from Bangalore for the first case, but there is no hard and fast rule. We request all the faculty to stay throughout the program so that you can guide the student for both the cases. And for the next, we have Dr. Hemkant Sharma from Jorhat, Dr. Poonam Mathur from Indore, and from Dr. Nalini Anand from Jamnagar. Today we have two cases, and we have students from Bareilly, Rajshri Medical Research Institute, and Dr. Sheila Jamal is the coordinating faculty. The another case will be from the student by Institute of Medical Sciences, Banaras Hindu University, and Dr. Sangeeta Roy is the coordinating faculty from that institute. Now, actually, we had earlier also case discussion on fibroid uterus. Today, we thought that we will discuss two cases of fibroid. In one case, we will discuss fibroid in a young patient, unmarried girl, so that when we rule out infertility in that, we will focus on myomectomy, different procedure, how to conserve the uterus, and mainly we will be focusing on the surgical part of myomectomy and how to preserve and take care of the fertility part also when this patient gets married. So that is our concept for the first case, and I thought Dr. Habibullah will be the best person to guide us on this matter. Then we have the second case, as usual, we commonly see in our day-to-day practice, perimenopausal women. In that situation, we are never worried about the fertility part. We just take care that whether we want to treat the patient with medical management or with the surgical management. But today, my emphasis will be on surgical management, that we teach our student, we guide our student about all the surgical procedure, endoscopy, laparotomy, and all these things, even NDBH also, so that they are all well versed with all these things, so that they are aware, because they don't find any time to discuss all these things in their day-to-day practice. So that is our idea today. And I hope my faculty will agree with me and focus only on these issues, so that we spend much more time and sort out these issues with our student. So with these words, I welcome all of you to this program. And the purpose again of this program is that we, from the nation, different parts of the country, we have different faculties, we have different students from different parts of the country. So they give their inputs, they discuss the topic, so that all variation or whatever the concept, different parts of the country, those are all concentrated into one thing, and our students are benefited from that discussion. So with that idea, this program has been conceived, and we are on this agenda now for last almost 2 years, and I hope we are giving some benefit and some guidance to the students also. So with these words, I will start this program, and I request Dr. Ashish Mukhopadhyay sir to say a few words, and then we will request the student to present the case.
Yes, good morning, everyone. Thank you, Dr. Ashok Kumar, and our grateful regards and thanks to the FOGSI officials and our ICOG chairperson and the ICOG team And as you have come to know by this time, the last 1.5 years, we have been trying to promote case presentation on the exam pattern or exam format for our PG students. And this has been an effort which is ongoing and will continue. And we have a lot of discussion among ourselves. It is not reflected to you, but we have a lot of brainstorming and discussion about the pattern of case presentation and all these things. And the result is that we may take up now onwards the topics once again, when some of the students may have missed that, and some of the students, they don't go to the website, as actually all the programs have been recorded in the website, but I don't find many website hits now. So I thought that I will request all the teachers to insist that the students should go into the website and look for the whatever individual cases they want to see. And this today, for instance, Dr. Ashok Kumar's idea was that let's take up a simple topic, but covering two aspects, two spectrums of life in the reproductive age group and the younger age group. So that was the idea generated by Dr. Ashok Kumar. Very noble idea. He's always a very thoughtful teacher. So keeping respect to these wishes and our discussion, the result is today. So as he said, he has pointed out that the young unmarried girl, fibroid uterus has a different presentation, different priorities, and whereas the postmenopausal women will be a different set of games. So therefore, I think these two spectrums, if you can cover, I think, and also he insisted that the surgical management, which has been a neglected part, that should be covered. So with that in mind, I welcome all of you. And I think it is time that we should discuss all these issues with our students also who cannot participate this. And the first case will be presented by Rajeshri Medical Research Institute, Bareilly. And as you have already known, and this is actually a case on the young unmarried girl. So I will invite, I think, Dr. Shweta and Dr. Rupal, isn't it?
Yes, sir.
Yes, and guided by Dr. Shehla Jamal. I call her Bareilly ki Barfi, and she is a very involved teacher. I have seen her in her past appearances. So I would like to request this thing, Shweta and Rupal, to kindly place your records or case presentation.
Yeah, before this, please start sharing your screen.
Yes,
Meanwhile,
sir.
I just want to remind once again everyone that all for last 2 years, whatever program we have done, all these recordings are available on the ICOG website. So you can take the benefit, you can go through those recordings of the different cases and just see what all you have missed while you're studying your books, so that you can add on those points in your knowledge bank. So with these, Dr. Shweta, you can start your presentation.
Good morning, respected teachers. I myself, Dr. Rupal Sihag, and my co-PG, Dr. Shweta Siwat, under the guidance of Dr. Shehla Jamal, will be presenting the case on fibroid. Patient Miss Rinki, age 21 years, nully gravid, daughter of Mr. Anuj, resident of Meerganj, Bareilly, which is 5 kilometers away from the treating hospital, Hindu by religion, and a student. The registration number was 111/12. Father's occupation, farmer. Socioeconomic history, residence, rural. Monthly family income, rupees 8,000. Socioeconomic status of the patient was poor. Date of admission was 20th May 2023 and date of examination was 20th May 2023. Patient came to the gynae OPD with complaint.
Excuse me. She's unmarried, no?
Yes, sir. Yes, sir.
That is not brought out. Nully gravid means she may be married and never become pregnant, isn't it?
Yes, sir.
That can be told. Another thing is socioeconomic status. Nowadays, there are so many classifications. You have to use one of them. In South, you use Kupuswami, you can use Prasad or something. Okay?
Yes, sir.
Go ahead.
Patient came to gynae OPD with complaint of lump in abdomen since 6 months, with abdominal discomfort since 6 months, and increased frequency with burning micturition since 5 days. History of present illness. Patient was apparently well and asymptomatic 6 months ago when she noticed the lump in abdomen, which was increasing gradually and associated with dragging sensation. Patient noticed tightening of clothes near the umbilicus along with discomfort. At present, she is complaining of increased frequency and burning micturition since 5 days with no similar episode in past. Menstrual history, age of menarche 14 years, regular cycle of 20 to 30 days with average flow for 4 to 5 days with soakage of 1 to 2 pad daily, not associated with dysmenorrhea. Her last menstrual period was on 10th of May 2023. Negative history, patient gives no history of bloating, constipation, early satiety, nausea, vomiting, no history of pain, denied sexual activity and was not taking any oral contraceptive, no history of fever with chills. Past history, no complaint of similar episode in past, no past surgical history, no gynecological complaint in past, no history of thyroid disorder or tuberculosis in self or contact.
Excuse me.
Family.
Excuse me. When the patient complained like this, what conditions came to your mind? Before you took a detailed history, what are in your mind? What diagnosis you thought of?
Sir, patient was complaining of increased frequency and burning micturition.
Before that, there was major complaint, another one.
Mass per abdomen.
Sir, lump in abdomen, and with that lump, she was complaining of abdominal discomfort also.
So what conditions came to your mind so that you can ask detailed history?
Sir, any GI complaint associated with this?
No, what is your diagnosis? You thought what conditions could cause this symptom?
So it can be a lump.
The patient is telling lump, you are also saying lump. Ultrasound fellow also will say there is a lump.
So ovarian tumor.
Yes. An abdominal mass or lump without any menstrual symptoms, first you should think of ovarian tumor. Okay.
Yes,
Till
sir.
it is proved otherwise. Okay.
Yes, sir.
So it need not be malignancy. The symptoms which you ask, early satiety, loss of weight and all that, they are seen only in malignant variety. It need not be malignant. It can be benign tumor also, no?
Yes, sir.
Benign tumor more common. Of course, what is her age? You said 20?
The 21 year.
21. At this age, malignancies also can be common, ovarian malignancies.
Yes, sir.
What ovarian malignancies?
So dermoid can be common.
Dermoid is malignancy.
No, sir, it's a benign.
Which group of malignant tumors are common in young ladies? Serous tumors, epithelial tumors.
Yes, sir.
No. I just gave a wrong clue.
Germ cell tumor, sir.
Say that. Right. Go ahead with the history. Okay.
Family history, no history of hypertension, diabetes, tuberculosis, thyroid disorder, or asthma in family. No history of malignancy in first or second degree relatives.
Past history, what did you say?
Sir, no complaint of similar episodes in past. No past surgical history. No gynecological complaint in past. And no history of thyroid disorder, tuberculosis in self or contact.
Okay. Right.
Family.
You told families.
Yes. Personal history, no history of known allergy or no history of addiction. In functional history, a normal appetite, normal sleep pattern, normal bowel movements. Nutritional and dietetic history, nutritional history, patient is a vegetarian with normal appetite with 1800 calories intake with 20 grams of protein intake daily.
Here I'd like to just stop and tell all the postgraduates, undergraduates also we tell. After all this history is given by the patient.
Yes, sir.
So can we say in general examination, I am examining a live patient?
Yes, sir.
A dead body?
Yes. Yes.
Can you
Live
say that?
patient.
You
Yes,
don't
sir.
say, no? So can you say patient is conscious after giving all this history?
Yes. Mm-hmm.
Should you say all this?
No, sir.
No, sir.
So please remove that.
Okay,
Yes,
sir.
sir.
Okay. Otherwise, before you started the history, you would have told me patient is unconscious. History is given by the attenders, which may not be reliable. That's what you would have said before starting the case, isn't it?
Yes. Yes.
So
sir.
don't say conscious. Especially in obstetric cases like imminent eclampsia, patient has received some sedation. You can say patient is oriented to time or not very cooperative, like that. Those words you can say that, but don't use the word unconscious when she has told herself in detail the complaints. Okay,
Yes, sir.
right.
Sir, I'll be starting with the examination. On journal examination, patient is cooperative, thin built with BMI of 18.1 kg per meter square. Vitals, her vitals are pulse rate 82 beats per minute regular, blood pressure of 100 by 62 millimeters of mercury, left arm in supine position. Her respiratory rate is 16 breaths per minute. Temperature afebrile, pallor present, no signs of jaundice or edema, no lymphadenopathy, bilateral breast and axilla appears to be normal. On systemic examination, CNS examination, as patient is cooperative, oriented to time, place, and person. On respiratory examination, bilateral air entry equal, normal vesicular sound. On CVS examination, S1, S2 normal and no murmurs present. On per abdomen examination, patient was counseled about the examination and consent was taken. Patient was asked to lay down in supine position with semi-flexed knees. After emptying the bladder, lower abdomen on inspection, lower abdomen asymmetrically enlarged in pelvic region more towards the right side. Skin overlying the mass appears to be normal, mass not moving with respiration.
Now, in lower abdomen, how can you say pelvic region? There are definite segments in the abdomen now.
Yes, sir.
Or what is this? Hypogastrium, iliac region, umbilical, lumbar, like that, your words you have to use. Okay,
sir.
hypochondrium,
Yes, sir.
epigastrium. Okay, not pelvic region. Pelvic region, you are not able to see per abdomen.
Yes, sir.
Okay. So is it in the hypogastrium?
Yes, sir. Hypogastric.
More towards right side. Also
Yes,
that
sir.
right iliac region also. That. Okay.
So umbilicus central and inverted, no dilation.
Don't say on inspection mass. It's only distension you are saying.
Yes, sir.
Mass only on palpation you will get. It may be gaseous distension. We don't know. We cannot put a hand. Okay.
No dilated veins or scar marks, all hernia sites intact. On palpation, huge mass corresponding to 20 weeks gravid uterus, which was firm, irregular, non-tender, mobility from side to side and from up and down, bossylated surface, lower limit of the margin could not be reached, not fixed to the overlying structures. Skin overlying the mass had no rise in temperature. No other separate masses felt, no hepatosplenomegaly, bilateral renal angles shows no tenderness.
At this, you tell me per abdomen, where is the height of the mass? 20 weeks means where exactly?
Sir, so at the level of umbilicus.
At the level of umbilicus, upper border, we say 24
Upper,
weeks.
yes, sir.
Weeks. Lower
So
border,
lower,
we said 22 weeks.
so lower
Sir.
border of umbilicus.
It is below the umbilicus only 20
Yes,
weeks.
sir.
Okay, right.
Yes, sir.
Then, how do you differentiate per abdomen? Okay, whether it is ovarian tumor or fibroid uterus. One of you just tell me clinically how will you differentiate ovarian tumor from fibroid uterus by abdominal examination.
So on palpation, the mass appears to be firm and
Which one you are telling? Which one you are telling? I asked
sir,
you.
I'm telling about the fibroid, sir.
Okay,
On
right.
palpation, the mass appears to be firm and it is irregular and it moves from side to side and up and down, and the consistency, sir,
It
which
moves
tells
from,
us about.
listen, it moves from side to side and up and down. Is it fibroid?
Yes, sir.
Fibroid is fixed by ligaments lower down. How it will move up and down? That is the single differentiating point between ovarian cyst, benign tumor and fibroid, that ovarian tumor moves in both axes, side to side and above downwards, whereas fibroid will move only from side to side. Isn't it?
Yes,
Yes,
sir.
sir.
And fibroid is firm. Ovarian tumor can be, if it is benign, it can be usually cystic, or it is, as in this case, there is germ cell tumor, it can be firm. Rarely fibroma, which will be firm. That is very rare. Okay.
Yes, sir.
Anything else? Abdominal examination finding. Irregular, you told. Irregular bossylations more suggestive of
Fibroid, sir.
fibroid. Bilateral masses, both sides, two iliac foci, two separate masses are there, more likely to be
So ovarian.
ovarian. Yes. Presence of ascites.
Yes, sir. Ovarian, sir.
Ovarian.
Ovarian. All these you have to tell. So lateral mass, bilateral mass with ascites maybe without ascites in early stage, okay? Whereas a subserous pedunculated fibroid can move in all directions. Exceptions. I am telling the general rule. There will be exceptions for everything. Okay.
So on local examination,
Suppose there is hepatomegaly, it may be due to ovarian metastasis. That is the extreme.
Yes,
Or
sir.
there is the upper abdominal thickening or mass, which suggests omental deposits. That usually says it is malignancy. Okay. Upper
Yes.
abdominal, separate thickening or mass in the epigastrium. Okay.
So on local examination, the external genitalia.
Don't call it
appears-
local examination. Why are you calling it local? Patient's complaints are abdominal. So that should be local, isn't it? In general surgery, if patient comes with ulcer in the leg, they call it local examination.
Okay, sir.
We examine the whole thing, whether patient complains of white discharge, mass abdomen, or vomiting in pregnancy. We have to examine the whole patient. So there is nothing like local examination. Okay,
Yes, sir.
right.
So external genitalia appears to be normal. Per speculum and per vaginum examination was withheld as the patient was unmarried, virgin female, and not giving consent for per vaginal examination. Per rectal examination was performed after the consent. It was performed gently, in which the cervix was palpable. Uterus and mass was not palpable separately.
Okay. In a married woman, or let us say in a married woman, when you do a pelvic examination, you are allowed to do a bimanual examination.
Yes, sir.
How will you differentiate a fibroid and ovarian tumor?
Sir, by manual examination, sir, from the right hand, the left hand in the vaginal examination, in the left hand, so we can differentiate with the groove sign.
Which one? In which condition you are telling me groove sign?
So
To differentiate between ovarian and fibroids. Sir.
No, in which condition there will be a groove?
So
Sir,
in
My
Sir,
question
any-
is,
in
how
fibroid, sir, in fibroid, the transmitted movement is present.
no, we are talking about groove, no?
Yes, sir.
I am asking about
ovarian, sir.
what you told
Ova-
only I am asking.
Yes, a groove sign will be present in ovarian.
Ovarian, okay. So the mass, if there is an abdominal mass, it will be continuous with the cervix. Okay. If you are feeling a mass in the fornix, let us say it is in the fornix, there is mass. It will be continuous with the cervix and with the uterus. In ovarian tumor, there will be a groove, gap between the two. Or in adnexal mass, there will be a groove. Anything else?
So
That is-
in fibroid, so we can see transmitted movements.
How will you say transmitted mobility?
So when we
How will you elicit transmitted mobility?
so when we do the per vaginum examination, and one hand will be on the abdomen, and we move the mass per abdominally, the transmitted movement, the cervix will also move along with the mass.
Right, that's what you said. So if it is uterine mass, when you move the abdominal mass, the cervix also moves.
Moves with the mass.
Not so in ovarian. If it is ovarian, cervix will not move. Right. Same thing in PV, you can see bulging Pocho Douglas. If there is a bulge, clinically per abdomen, you might not have felt the ascites, but sometimes there will be ascitic fluid in the Pocho Douglas, isn't it? That goes more in favor of ovarian malignancy. If there are nodular deposits, not in this case, 20-year-old, I am not talking, okay? If there are nodular deposits in uterosacral or Pocho Douglas, goes more favor of ovarian cancer. Okay?
Yes,
Yes, sir.
sir.
Which other conditions there can be nodularity in the posterior fornix or uterosacral?
So
Endometriosis.
Endometriosis. This patient can have endometriosis, no?
yes,
With
sir.
fibroid? Right. Those symptoms are not there. Anything else? PID? Pelvic tuberculosis?
Yes, sir. Pelvic
Yes, sir.
tuberculosis.
Malignancy deposits, cancer cervix or something involving uterosacral ligaments, endometrial cancer, cancer cervix, all these can involve uterosacral ligaments. Like it involves parametrium, it can involve uterosacrals also. Tuberculosis, already I told you, PID.
Yes, sir.
Okay, sometimes septic abortion, these things. Okay, go ahead. Summarize.
Patient Miss Rinky, 21 years old, unmarried, nully gravid, came to the gynae OPD with complaint of lump in abdomen since 6 months with increasing frequency and burning maturation since 5 days. No similar episode in past, no history of tuberculosis, no gynecological consultation was done. Neither USG was done. After complete history and examination, a mass corresponding to 20 weeks gravid, uterus, irregular, firm, solid pelvic mass on rectal examination and uterus were not felt separately. My provisional diagnosis is fibroid uterus with UTI, urinary tract infection with mild anemia.
So your rectal examination was inconclusive. You could just feel the cervix. You have not felt the mass.
Yes.
How can you
Yes, sir.
say uterus and mass not felt separately? How can you say? You have not even felt the mass. Rectal examination, you could just touch the cervix. That's all. You have not felt any mass, isn't it?
Yes.
Yes, sir.
So that is not a finding to be told. Okay. Provisional diagnosis, fibroid uterus.
Any other differential diagnosis we can have apart from ovarian tumor?
So we can have a first, which is mostly missed, that is full bladder. And
Okay.
another one could be pregnancy and fibroid, adnexal mass, ovarian tumor, gynecological masses, endometrioid or dermoid, non-gynecological
Please
masses.
listen, please listen. Is fibroid,
Sir,
adnexal mass, ovarian tumor, all these are not gynecological masses?
Yes, sir.
They are.
And
sir.
why you are saying separately gynecological masses again? Dermoid is ovarian tumor. You have written separately again, dermoid. Right.
Sir, can I, with your permission, can I add something more here?
Please,
Yes,
sir.
yes, Dr. Kumar.
Yeah, please go back to the previous slide. See, as sir has told that we have not done the PV, we have on PR, we cannot feel that 20-week size mass on PR, that is very sure. So we are not sure what we are dealing with. So can you say fibroid at this junction? My query is this. And I will prefer to say, because we have not done the PV, then it is better to say we are feeling a midline abdominopelvic mass. That will be our, and so what do you say, sir, Dr. Habibullah, sir?
Yes, you are right. You are right. Though abdominal
Because fibroid we
examination,
cannot name it.
yes, though abdominal examination goes more in favor of fibroid uterus, you cannot be sure. So you can say that, no problem. But if you
Because
have
we have not done the PV.
you see, if you have to commit, sometimes right or wrong doesn't matter. Provisional
Yeah.
diagnosis is only provisional, so that you can do further investigations.
So
You,
regarding
you can be completely wrong in giving a provisional diagnosis, but there needs to be diagnosis. So in that case, is more likely fibroid uterus, I'll say. What do you? Is
So
it?
regarding
So
adeno
last line you have to, and
Yes, I would
just
like
for a
to
minute.
begin-
And last line, and just for a minute, sir. And
Yes.
last line, you have to, when we talk of provisional diagnosis, we have to complete the provisional we have to say the complete provisional diagnosis. You start with the age of the patient and complete the diagnosis. It is not just that in one word you will say fibroid uterus, right? I think you know all these things, but here somehow we have omitted that thing. So try to present a
What
complete
sir is
provisional
telling is, you
diagnosis.
should say
And as-
21-year-old, unmarried, like that. You have to give a full sentence diagnosis, provisional diagnosis. That's
Yeah,
what-
I have a provisional diagnosis and the case summary, which I would like to present at the end of this discussion. But before that, I'd like to take up the matter of
Yes, sir.
provisional diagnosis. Sir, provisional diagnosis is provisional. I fully agree with Professor Habibullah that from the clinical examination, from the history, from the general survey, from the abdominal examination, if one is suspecting something, he or she is authorized to write a provisional diagnosis or a clinical diagnosis or a working diagnosis, upon which you will build your case and you will suggest the investigations accordingly. So there is nothing wrong writing the leiomyoma uterus, the very common benign condition of the uterus, which is arising from the pelvis and going into the abdomen. So that is my observation about the provisional diagnosis.
Right.
Actually, what happens, sir, most of the students, they're very scared of writing a provisional diagnosis. Provisional diagnosis writing is the art you have to develop by this detailed action of history and general examination. I would further like to make my comments. If you go to the first slide, please. Go back to the slide. I have got some observations which are reserved for this case, which I will share with you. Yes, I agree with the first slide, please. Yes, I agree with Dr. Habibullah that you should mention here unmarried. Okay, nulligraphy doesn't mean the marital status, so therefore I think that should be added here. Staying 5 kilometers away from the hospital is important, more important in obstetric cases, because they have to avail the obstetric services from how much distance of the hospital that we have to note. That is why the distance component is there. In the second slide, you have written the gynae OPD with complaint of lump in the abdomen. Next slide, please. Yeah, lump in the abdomen since 6 months, abdominal discomfort since 6 months, and increased frequency with burning micturition since 5 days. So that is not a chronological order. Chronological order means that they have to time of appearance. According to time of appearance, you should write that. Anyway, this will be okay. And the history of presentation, other things are okay. Menstrual history, what is the most striking feature you see? There's a delayed onset of menarche, delayed age of menarche. And I think the student should note that and mention in the summary. Regular cycle is absolutely, in this particular case, menstrual history is extremely important because the patient is producing, we are suspecting a case of leiomyoma or fibroid uterus, and menstrual disturbances is very common there. And there is no other observations in the other histories. The histories are written more or less well, but I am not convinced with the dietetic history, nutritional dietetic history. It could have been a slightly more detailed. Vegetarian, 1800 kilocalorie and 20 grams of protein. Do you think that the 20 gram of protein intake is sufficient in a young growing girl? That is a question we have to think about. In examination, say systemic examination, other things I will skip. I will go to the summary, presentation of the case, and I would like to the host to allow me to share the screen so that I can share the summary with you. Now, summary is one thing which the students must be, very, very conversant with, and they should practice summary writing, because summary is the thing which you present to the examiner. Whenever the examiner comes to examine this case, the first thing he asks is what is your case? Now, the students get confused because what will they say in response to this question? Because the case sheet is not in your hand, it is taken by the examiner. Okay. So you need to practice the summary writing very well and present it as just like a storytelling to the examiner, so that the examiner also can come to a provisional diagnosis after listening to your story. So here is the case summary which I propose to you, and somebody can write it. Can I share my screen now?
Yes, sir.
Yes, sir.
Yes, sir. They have stopped sharing.
Can you see the screen now?
Yes, sir.
You can see. Okay. So I have written it just a sample. You can modify it. Just written right now. And this is an example of how you can present the case to your examiner who has come to see the case for the first time. So Miss R, remember, if you write MS, it also means married and unmarried girls. So I will prefer to write Miss over here. R, do not write even the full name also because of confidentiality. 21 years, age is very important. An unmarried nulligravida belonging to a low socioeconomic status family and staying nearby, came to our gynae OPD with complaint of lump in her lower abdomen and resultant discomfort since last 6 months, and increasing frequency and burning micturition since last 5 days. The lump was a slow growing one, that is your inference, and the discomfort increased gradually over last 6 months. No similar episode in the past, no past history or family history of FOGSI, diabetes mellitus, hypertension, or gynecological malignancies. No history of any surgical operations, neither was any gynecological consultation sought, nor any ultrasound was done. Her menstrual history is marked by a slightly late menarche, but at present she maintains a normal menstrual cycle with average flow and absent pain or clots. She strongly denied any sexual activity. There is no history of vaginal discharge or fever. She has no significant personal history of allergy, addiction, or drug reactions, and her functional history of appetite, bowel, and bladder habits in sleep are normal. She has been a vegetarian throughout with daily calorie intake of 1800 kilocalorie, probably deficient in protein. On general examination, she is alert, oriented, and cooperative, thin built with BMI of 18.1 kg per square meter. Her vitals are stable with normal pulse, blood pressure, and temperature. Apart from mild pallor, no other significant findings were found. Examination of breast revealed no abnormality, and systemic examination is unremarkable. Abdominal inspection revealed a midline bulge, which on palpation was found to be quite a sizable mass corresponding to 20 weeks gravid uterus. Firm in feel, irregular, non-tender, and mobile from side to side, but restricted movement in the y-axis. It has a variegated surface, lower limit of the lump could not be reached, and there is no groove failed. Per-vaginal and digital rectal examination are withheld as they were thought to be uninformative and painful as the patient is unmarried. Suprapubic tenderness was observed and palpation of this area provoked urge of urination. My provisional diagnosis will be young unmarried girl with symptom-producing leiomyoma uteri with UTI and mild anemia. You can modify this according to the need of the case, but this is a standard, a sample of how you should present the case. Summary doesn't mean a very short case, but it has to contain all the components of the history that you have taken, all the examination materials, and then provisional diagnosis is not just one-liner of fibroid uterus. You have to write this. Young, you can write the age also here, doesn't matter. Unmarried girl with symptom-producing leiomyoma uteri with UTI and mild anemia. So I think this is a sample and you can modify this. Yes, Dr. Habibullah and Dr. Ashok Kumar to comment on this, and then the students.
It is very good, sir. But the only thing is examiners, after listening to the whole history, do not have patience again to listen to long summary like this. I am telling you. The time for a long case is only 20 minutes.
Sir. I have practiced this over a mirror. It took only 2.5 minutes. Actually, it looks long, but if you say it in a flow, if you can say it in a flow, I think they should develop this habit of speaking in front of the examiner.
This applies for short case. What is your short case?
No, actually,
tell this.
Yeah, actually, sir, that is what we are practicing, is that because sometime in the exam, directly examiner asks them, no, don't present the case, just present, tell us the summary.
In that case,
these things are important. Yeah. So this is the practice we are giving them to the student, that they should know how to summarize the case also.
Yes. In that case, it is very good. But
and most important thing is the students are really confused as to how to start and how to finish. And these 3 minutes of their life, then nobody can take them away, because this is their first presentation in life. And if you can make a summary, and this is just a sample, if you can make a summary, something like this, and practice and commit to memory many times, and then you will be able to say something. You are not standing silent in front of the examiner, and therefore the examiner will listen to this. And then the examiner will be able to make a provisional diagnosis along with you. That is the purpose of writing a summary.
Yes.
And you may or may not keep it written in the statement, because while you are telling the summary, the examiner is going through the sheet and he is confirming the findings, anything which is missed or not. So he can always ask. And yes, there is a possibility in some cases, 5% of cases, what Dr. Habibullah and Dr. Ashok Kumar has said, that the examiner will stop. No, don't need to present the case. Just tell me the short abdominal finding, something like that. Or tell me your diagnosis when the examiner is short of time. But that apart, I think most of the things, for beginner, it will be okay. At least you prepare your summary, get it ready, and be prepared for the presentation. And then the examiner, let the examiner take it.
That is what we always insist.
Yeah.
We always insist with the student that obviously they should, number one, learn how to present the case. Number two, they should learn how to summarize the case. Number three, they should tell and learn how to tell us the provisional diagnosis. So these three are the important beginning. In the beginning, they should know all these things. And then we can go to discussion at any length.
So now, Dr. Habibullah, you can take up the crossing also, the rest of the crossing that is there. And I think that students, I can share this in your group and you can practice it. You can...
Dr. Sheila wanted to, Dr. Sheila has some comments, I think.
Yeah.
Yes,
Dr. Sheila.
Madam, you wanted to tell something.
Please.
Sir, what sir said is correct. Like this only we have to summarize and present. It is a very nice one. Everybody should learn it, sir.
So I will share in the
So,
group.
now
You-
Yes,
this
sir.
is the, yeah.
Yes, sir.
So this is the case and we have the provisional diagnosis. Now, students,
yes.
you can start with how to manage this case. How will you start the
Investigation
management of this case? What will you do with this patient? Yeah.
So
Yes.
you have a provisional diagnosis, so you need to confirm your diagnosis. Provisionally, you have made a diagnosis of fibroid uterus or leiomyoma. Okay. Now you have to confirm or rule it out.
So how do you confirm the diagnosis of leiomyoma uteri? Your own proposed provisional diagnosis, how to support that, and how to negate the other differential diagnosis. And secondly, the list of differential diagnoses.
You can stop sharing.
Yeah, of
You
course.
can stop sharing so that we are on the.
Yeah. The comments made by
Yes,
Dr.
now.
Habibullah about the differential diagnosis is absolutely correct. There is no point writing separate gynecological masses. You know, you don't just increase the number of list of differential diagnoses. That doesn't help. You know, that just shows the examiner that you run out of ideas. So full bladder is okay. Pregnancy is also okay. Fibroid, you don't need to write here because that is your provisional diagnosis.
Yes.
That is why I don't need to write the fibroid in differential diagnosis. Gynecological masses that don't mean anything. Then non-gynecological masses, of course, you can mention one or two. So I think that probably that differential diagnosis will be 4 or 5, 3 or 4. Don't increase the length of the differential diagnosis unnecessarily just for filling the list. It doesn't help because you will be yourself will be baffled by the question which they come in when you go to differentiate from the diagnosis. Yes. Now, what investigations would you like to go for in this particular case?
So here we'll firstly get the complete blood count done as the patient looks anemic. And so next investigation would be the ultrasonographically, the
So you need to
transabdominal
know
ultrasound.
how the investigations are going to help you in supporting your provisional diagnosis or excluding other diagnoses. So how does a complete blood count help you? Of course, the patient has anemia that you have mentioned. Pallor is there. You can confirm anemia. That is true. But apart from that, any other thing that it helps?
So the TLC count. And it will tell us
Urinary tract infection, so we can rule out with the help of the TLC count.
and
Then we can further go for urine routine and microscopy, urine culture and sensitivity.
Okay.
transabdominal ultrasound,
Okay.
which would confirm our diagnosis,
Which may confirm your diagnosis.
which may confirm our diagnosis.
What all things you'll see in the transabdominal ultrasound?
So in transabdominal ultrasound, so we can see heteroechoic masses if we are suspecting a leiomyoma, whereby we can see multiple fibroids or
Let us say there is one fibroid, 4 centimeters. Just describe how it looks in ultrasound. Let us say one small 4 or 5 centimeters fibroid is there. How does
Ultrasound description of suspected fibroid. You know, you need to convey this to your radiologist friend also. Because what do we write always? Ultrasound lower abdomen and pelvis.
Yes, sir.
You do not specify your clinical diagnosis. So make it a good point of whenever you are asking for an ultrasound, ask yourself, unless you are doing the ultrasound yourself, then you convey your clinical diagnosis or thoughts to the radiologist friend, because he will also look at it from that angle. Otherwise, you will be just running around here and there. He will not focus on the uterus unless and until you tell him that this is my provisional diagnosis is a leiomyoma uterus or fibroid uterus. He won't focus on that. Okay. So that is one important information which you like to get from the transabdominal. Remember, this case is different because we have the disadvantage of not being able to make a PV examination or a PR examination, par-rectal examination. I personally feel that par-rectal examination in such a big fibroid is not only useless, it is uninformative, it is painful for the patient.
Yes.
I don't support par-rectal examination. Just for saying in the examination, do not say something which you don't practice or you do not support or you cannot justify. I think that is my opinion. And also you cannot do a transvaginal sonography. So you have to get all the information, I mean, as much as practicable from the transabdominal ultrasound. That is why you must learn in such a case the transabdominal view or picture of or ultrasound picture of fibroid uterus. So this is a must question. You will definitely face it. Yes.
So,
Yes, how does a fibroid look by ultrasound? Tell abdominal ultrasound.
sir, on the transabdominal ultrasound, which will be done for the mapping of the fibroid to know the exact size of the fibroid, to know about the cavity.
No, you're telling whole mapping you're telling. I am asking a single fibroid, 4 centimeters. What features you will get in ultrasound? How do you say it is fibroid?
So
It will be, sir, heteroechoic.
I don't understand what is meant by heteroechoic. Please explain.
So it can be, sir, it can be hypoechoic as well as hyperechoic.
So tell when it will be hypo and when it will be hyper. You diminish the gain in ultrasound, everything becomes dark. You raise the gain, everything becomes white.
So if it is cystic, sir, it can be hypoechoic.
How common is 4 centimeter fibroid being cystic? Is it common to have cystic fibroid?
No, sir.
No, sir.
Centimeter? See, compared to surrounding myometrium, it is hypoechoic. That's what you should tell. You are comparing with the surrounding myometrium. It is hypoechoic, well circumscribed. It won't be irregular, star-shaped and all that, isn't it? That's what you should tell. Very simple. Mapping is different. How many are there? Where is it? That is, each one I am telling how will you diagnose fibroid, isn't it? How do you diagnose adenomyosis in ultrasound? Same thing can be adenomyoma in one corner. No? Generally, adenomyosis of the uterus, how do you diagnose by ultrasound? These are the common questions which will be asked when there is a fibroid case. Okay, please tell.
So students, kindly note that you need to, keep in mind and remember properly the different pictures of all these 3 common conditions: leiomyoma of the uterus, ovarian tumor, adenomyosis, adenomyoma, etc. All these pictures you should separately know and keep in your mind, because they can be asked anytime in the examination. And more importantly, in this case, because we have limited facility of investigations in this case. Your clinical examination is less important here because you are not being able to approach the mass digitally. That is the reason. So you must know it properly. So your statement should be a relatively hypoechoic area surrounded by, or rather from the comparatively more hyperechoic area of the myometrium, which is well circumscribed and well defined. You can say like that. Size approximately so and so. That also you can say. And the areas of hyperechoic and hypoechoic areas, alternating with one or presence of both, may be present. But most important thing is what Dr. Habibullah said, the hypoechoic area demarcated specifically by a boundary from the comparatively hyperechoic area of the myometrium. That is the most important thing you must say. Degeneration may come later. It may not be there also. So the alternate hypoechoic and hyperechoic inside the mass, you may not say, not that commonly, but this is most important. So any other thing apart from the size and the echogenicity of the mass? Anything else?
So vascularity can be also seen.
How do you see vascularity?
So on color Doppler.
Okay, if you have a color Doppler facility, then you can apply that. And
Where will you see the vascularity in a fibroid?
How is the blood cell supply of a myoma?
Uterine artery.
Is it in the capsule or in the center?
Uterine artery.
Charu Sharma has said it, given the answer peripherally. Yes. And yes, centrally it is avascular and the peripheral areas are.
Yes.
Okay. But remember, everything is happening within the capsule. The capsule, if you see the fibroid capsule, it is made from the myometrium only. It is more clearly defined by the ultrasound than clinically. When you go for operating these cases, you will find the capsule is not so well defined. But in ultrasound, you will find that. That is the unique nature of the fibroid uterus. Okay, anything else that you can see? Vascularity and anything else?
Situation are not going to check where exactly it is situated.
Pardon, madam?
Situation of the mass, intrauterine or subsequent intramural.
No, that yes, it has to be mentioned, and they have tried to start saying that first while saying my mapping. Mapping comes later.
Yeah,
But then this situation of the myoma, you mean relative situation? I mean, how much inside the myometrium,
Yes.
or how much protruding inside the endometrium,
Yeah.
how much
Yes.
protruding inside the serosa,
That's
all these
class.
things will come. But first, the description of the myoma, they should know. In any description, be it an ultrasound, be it an X-ray, be it an HSG, be it instrument, there should be an order of, how they say that. That's what I was referring to. Yes. So now lastly, come to the station of the myoma. Where is
Yes.
it situated? So
Right.
number, as you said, now Dr. Habibullah was focusing on one myoma. Now is the time that you have to roam around with the probe and find out how many are there in their respective sizes. At least the bigger ones, you must mention the sizes, the significant ones. How do you know this is significant one? Anything which is more than 4 centimeter or something like that, it should be mentioned. Small seedling myomas, neither you can see nor you need to describe, but the bigger ones you must describe. And then the location of the myoma. Where is it located? Is it completely inside the myometrium, or is it protruding inside the serosa, outside into the serosa, or inside into the endometrium? That you must mention. Anything else anybody wants to add here?
That FIGO classification you should know.
FIGO classification, can you do with the ultrasound completely?
Or
Yes.
anything else you want to use?
Or you need some other help of some other investigation that need to say, here lies your discretion of choosing your investigation.
Yes.
Now, that also depends how much important FIGO classification is it in the management. You may well apply your discretion that, sir, I'm not going to go into the FIGO classification because it is not relevant in my case. You can also say that. As a consultant, this is your discretion. Suppose the patient cannot afford an MRI, or you cannot have this in your system, and you think that the location of the myoma, exact location of the myoma is immaterial, then you can say that. But otherwise, you must say the FIGO classification nowadays, because all the examiners are well oriented with the FIGO classification these days. So any one of you.
Suppose you are going to do a hysterectomy for one patient. Ultrasound is good enough to diagnose fibroids.
Correct.
Only thing is you have to rule out, is there any broad ligament fibroid, is there a cervical fibroid? If you put it out, because then you may anticipate problems, whether you will do or you'll take the help of somebody that will decide that. Other than that, mapping is not necessary, isn't it?
Correct. Absolutely. That's what I said, that student can have the discretion of saying, suppose somebody doesn't have in the MRI in the system, or he cannot afford that, or something like that, or ultrasound cannot do that, then you don't need to say that. But wherever the facility is available, you are appearing in the examination from your own setup, and you are not responsible for the setup, right? So you say that in my setup, I don't get MRI that frequently or that regularly, so I cannot do that. Okay. But otherwise, you have to mention, because the examiner will then ask you, okay, you don't have the setup, but you tell me, how does the myoma look like in an MRI? That the examiner is authorized to ask you, because you should know by theory. Okay.
Now we'll go to diagnosis of adenomyosis, especially when the uterus is 12, 14 week size, 16 week size. Can you tell?
No.
Ultrasound features. Clinical, if you want, you can say clinical features also.
So in the ultrasound, there will be loss of the endomyometrial junction in adenomyosis.
Right. In the myometrium, what do you see?
So cystic, salt and pepper appearance, cystic, you
Okay.
can find in
Cystic
cyst.
areas, then
Yes, sir.
Diffuse.
That's what heterogeneity in texture.
Yes, sir.
That's where you use the word. Okay.
Bulky globular.
Catchy terms
features.
you should use, but then they should not take they should not predominate over your clinical findings.
Yes.
Salt and pepper appearance, snowstorm appearance, all these things we love to say.
But
Examiners
describe it.
also love to hear
Describe it.
them.
First describe it and then say it is.
Yeah. I think you should not be carried away by catchy terms.
Uterus is rather uniformly enlarged.
Yeah.
There is a differential thickening of the myometrium.
Yes.
Yes.
Which wall is more commonly involved? In adenomyosis, which wall of the uterus is more commonly involved? Posterior wall.
Posterior.
Say that. You have to tell all the features. Usually,
Everybody is agreeing to posterior, so it is posterior.
so differential thickening of the myometrium, cystic areas in the myometrium, breakage in the endomyometrial junction, anything else? Any lines?
So grossly enlarged uterus.
She told anything else?
Yes, sir. Tenderness would be present on clinical examination.
No, I'm asking ultrasound, you jump to clinical examination. Okay, tell clinical examination, what are the findings?
So on per abdomen examination, so on palpation, there would be tenderness present, grossly enlarged.
So uterus will
Uterus.
be enlarged up to 10 to 12
12.
weeks, and
Usually,
it will be tender in
usually in adenomyosis, uterus will not be unusually enlarged like 20 weeks, 30 weeks like that. Okay. So,
Only 14 weeks.
and usually it won't be irregular bosulated. There may be one adenomyoma, little bosulation, one place it may be there. Okay. Like in fibroid uterus. And especially immediately after menstruation, if you examine the patient, there will be tenderness. And the symptoms of dysmenorrhea and heavy menstrual bleeding. That's what. And she is not a nulliparous woman. Usually parous women in the nearing 40s, you get adenomyosis. Whereas fibroid uterus more common in nulliparous in 30s. Okay, late 30s and all that more common. Okay.
yes,
That's
sir.
Yeah.
what you
So
start
this clinical differentiation is very, very important. And I would like to add over here that this is the important differences between a leiomyoma or a fibroid uterus and an adenomyosis is largely, it is that the adenomyoma is a self-limiting procedure. And that is why unlike myoma, it doesn't grow to a huge size like 20-24 weeks. Okay. Patients are also brought to the doctor faster than the myoma because that is not symptom producing. So growth of the adenomyosis is entirely different from the growth of the myoma. You need to know the differentiation between these two clinically, and then only you will be able to describe it by ultrasound. So ultrasound examination of an adenomyosis, I think the most important thing that you should observe is there is no definite capsule like one you used to see in a leiomyoma. That is one important. And then all these descriptions will come one after another. The cystic areas, the appearance of the myometrium, the diffuse areas, localization, etc., the salt and pepper appearance, etc., etc. So I think that the major thing that you want to convey to the examiner is that I know the etiopathogenesis of the myoma and the adenomyosis completely. So the ultrasound is just a picture. I have got a clear mental picture, clinical picture of the condition in my mind. That will be reflected in the ultrasound. That you must convey. Okay. Sir, you want to ask anything else?
Fibroids can be asymptomatic generally. Yeah. It can be accidentally discovered. That is all okay. But which fibroids are least symptomatic?
Which variety of fibroid uterus?
Subserosal.
Okay. What percentage of fibroids are subserosal? What percentage are intramural? What percentage are submucous?
Subserosal are 40%.
Subserosal.
Around 40.
Intramural?
10.
This is a common basic understanding. First thing, fibroids
30%.
arise in the serosa or mucosa or myometrium. Yes, please. Don't make me ask this question. Leiomyoma arises where?
So from the myometrium, so.
So that should be the commonest. 70% are in the myometrium. Intramural are 70%.
With different grades.
Okay. That may be okay, this side, that side, and ultimately intramural 70%. About 15% go to the cavity, towards the cavity, submucous that is. About 10% are so subserous completely. Okay. The rest a few, 2 to 4% may be cervical fibroids. It can be in supracervical, polyp, anything, all these together. Okay. So 70% are intramural. So this patient can be subserous fibroid because initially when you mentioned the movement, you said both in both axes it is moving, making me suspect that it is a subserous fibroid which is not symptomatic. That's why probably Otherwise, what will be the symptoms of fibroid? Common symptoms, enumerate 1, 2, 3, 4.
Heavy menstrual
Heavy
bleeding,
menstrual
sir.
bleeding,
Yes,
dysmenorrhea,
okay.
Why
And
does
so
dysmenorrhea occur in a
pressure
fibroid
symptoms.
uterus?
When you are saying about bleeding, all types of bleeding you should tell.
Yes, sir.
Most of the fibroids will cause heavy menstrual bleeding.
Heavy menstrual,
Some will produce intermenstrual bleeding.
intermenstrual bleeding.
Which ones?
in
So,
such in case of polyp.
Cervical,
Right.
cervical
Now
one.
finish bleeding, then go to pain.
Yes,
What
sir.
sort of pain you'll get?
And why the pain occurs?
Pain during
So
period.
pain,
Cyclical.
Pain during periods is different. Pain in between periods is different.
Yeah.
Yes, sir.
Okay, dysmenorrhea, you tell. Congestive dysmenorrhea is the most common. A few cases, submucous fibroid, when uterus tries to expel it, may have spasmodic dysmenorrhea also. Besides this, what is the cause of pain in a fibroid? Suppose somebody comes with severe pain in a fibroid, what is the cause? Non-fibroid uterus comes with acute pain.
So maybe due to degeneration.
All degenerations will produce acute pain.
no,
So if the mass is, if the fibroid is of large size and it is
Now,
producing
please,
any
what type of degeneration will produce pain? Red degeneration.
red degeneration in
degeneration.
second
Though it is
trimester.
more common in pregnancy, it can occur in non-pregnant state also. Okay. Anything else?
So
Very
due
rare.
to torsion.
Torsion,
Okay, very rare. That is pedicle, torsion of pedicle.
Upstairs, yes.
Okay. Then inversion, chronic inversion, the dragging pain it can cause. But in a perimenopausal, postmenopausal woman, especially if there is pain and rapid growth, what do you suspect?
The sarcoma.
Sarcomatous degeneration, which is very, very less common. 0.1 to 0.4%, maximum 0.5. Okay. So you can see in 3 months, a mass which was not palpable per abdomen suddenly becomes 14, 16 week size with pain and maybe bleeding, especially in perimenopausal, postmenopausal women. Okay. Maybe patient is on tamoxifen therapy, all these risk factors. Or patient had radiotherapy for cancer cervix or something. History is there, then they may develop sarcoma. Okay. Now, in this case, sir, shall we go to the treatment? Because we are...
So actually, I wanted to ask them that in this patient, we have got a very important clue and we should catch hold of that. This patient presented with UTI. Now, this could be the fibroid could be an originating factor for the UTI as well.
UTI,
Can
yes.
someone explain this to me?
So due to the pressure symptoms.
Yeah.
And so, or me.
Sir, if there is a cervical fibroid, it can produce a compress and produce a retention of urine. Or if there is a large
That is a
posterior wall
direct effect on the
fibroid,
bladder. That is direct effect. But in this
Yes.
case also, the patient can have this kind of a symptom. I'm not saying for sure, but then it can happen that the fibroid uterus, which actually, you know, that that enables the bladder to be pushed up, and in the process, the bladder cannot empty itself properly. So there is always some amount of residual urine in the bladder, which may ultimately lead to cystitis and urinary tract infection. So that should be the explanation given to the examiner.
yes.
Another question I wanted to ask: why the fibroid causes pain? Sarah has explained everything, but then you must not forget that the basic mechanism is the body wants to expel the fibroid. And that is why it gradually becomes some subsidus into the submucous and then in the polyp. So that is a very important cause of pain. Body treats the fibroid uterus as a foreign body. You know, so that is the reason why the body tries to expel, and the uterine contraction pain is very, very severe. That you have to say, apart from other causes.
Before
Now,
you
sir,
go to
let's move
management,
to the myomectomy. Let's move on to the
sir,
myomectomy.
just one question before we go to the management.
Yes, sir.
What are the complications of fibroid? Usually in the exam, we ask this and invariably students give some wrong answer. That's why I'm asking. Complications of fibroid. Please enumerate.
The degeneration.
That's what. These are secondary changes. They are not complications. See, when you grow old, what are the complications? I have gray hair. So is it a complication? Having gray hair, wrinkled skin and all that. Okay.
So,
Arteriosclerosis, osteoporosis, these things are complicated.
yes.
Okay. So amongst degenerations, red degeneration is a complication. Sarcomatous degeneration is a complication. Pedunculated fibroid undergoing torsion, bleeding hemorrhage from a fibroid is a torsion. Chronic inversion is a complication. You should tell like that. Okay. We will also usually ask what conditions may be associated with fibroid uterus. So you should tell all these: endometriosis, PID, myohyperplasia, adenomyosis, endometrial cancer. You have to enumerate. Very rarely erythropoietin causing polycythemia. All these things you can tell. Okay. Now go to the treatment. Sir, we'll go to the treatment because we are little running out of the time. Sir, Ashok Kumar, sir.
Oh, I thought we will
Yes,
focus
sir.
on
Yes.
myomectomy in the next case. Dr. Ashok Kumar wants it in this case only, is it? Right?
Sir,
Yeah.
in this in the next case, we'll focus on hysterectomy by
Okay.
various routes
Yes,
fine.
and by various methods and various methods.
sure.
So let us say we have confirmed the diagnosis of fibroid uterus by
And then treat.
whatever means.
So since the time is limited, I'd suggest that let us omit the medical management of myoma, isn't it, Dr. Ashok Kumar? And then we go straight away to the surgical management.
Yeah, surgical management.
That will give us some time. Yes. So the student should tell us what are the surgical treatment options available in this patient. 20 weeks fibroid uterus in unmarried girl.
So first is hysteroscopic myomectomy can be done.
With a big fibroid, felt per abdomen, moving, all this. First you are starting with
You have to
this.
devise a special hysteroscope for this.
Myomectomy, which can be done by
So laparoscopic myomectomy or abdominal myomectomy?
Which one you prefer and which one is feasible out of the two?
Um,
20
So
weeks
preferably
fibroid, a large.
laparoscopic.
If it is a large fibroid, is it easy to
Sir,
do by laparoscopy, or you enable it to do by laparoscopy, or to give a suprapubic incision and remove it? Can you do something to reduce the size of the fibroid so that it is amenable to laparoscopy, and probably a smaller incision, low down transverse incision by laparotomy for both these?
so GnRH analogs can be given to decrease the size and of the fibroid before the surgery
Name the
and to
drug,
minimize
name the drug dosage and duration.
So
leuprolide.
ganirelix and leupurides.
I'm sure you have prepared this topic for 1 month or so and come and you are not prompt in answering. Okay, leuprolide 3.75 milligrams intramuscular
Once a month.
monthly. How many months? 6 months, 9 months?
So 3 to 6 months.
6 months you will give in this patient.
3.
Your aim is to reduce the size of the fibroid, no?
Yes, sir.
Then each injection also costs, more than 3,000 rupees, nearing 4,000. 3 injections itself 10,000. And for surgery again, she has to pay. 3 injections will reduce the size by how much? 50%.
40 to 50%.
50%. Roughly, round figures you remember easy. Okay. 43.5% and all that. Till tomorrow only you'll remember. Next month you won't remember. Okay. 50% reduction after 3 injections. Okay. Reduces the vascularity. Makes it easily operable by probably by laparoscopy, or if you are not, low transverse incision also it can be. But what is the difficulty in during surgery if you have used GnRH?
So it causes hypoestrogenic state. So
That is before pseudomenopause, it will produce, you'll have symptoms of menopause, atrophy of the breast and all that, hot flushes. You can add back therapy, you can give, that is all okay. During surgery,
So-
what?
Surgical plane will be
destroyed.
Okay.
and sir, the seedling myomas can reoccur
Disappear,
if
can
you are doing the
disappear.
surgery.
May
will
not be
reduce in
diagnosed,
size
they
and
may come up
after.
afterwards. Okay, these 2 disadvantages at least you must tell. Okay, what are the alternatives nowadays to GnRH analogs? We have been using. For some years, we have been using progesterone receptor modulators. Ulipristal, but there are some
Ulipristal,
concerns about hepatotoxicity. So we're a bit cautious,
Isopress.
but which is relatively safer drug now we are using.
Mifepristone, so
How much dosage? For anything, you must tell the dosage.
5 to 50 milligrams. So
5 milligram is too less.
5 to 50 milligrams. So
5 to 50. Usually 25 milligrams. Even people have tried 10 milligrams also. Continuously for 3 months you have to give. That's also expensive. Okay. At least it will cost 40-50 rupees per day. 25 milligram tablet. 3 months you have to give. There are not many side effects. Unlike GnRH, it does not produce any menopausal symptoms. Reduction is good enough, 40% like that. Only concern is slight increased chance of endometrial hyperplasia, which is of not concern right now. Okay, that's what they are saying. Okay, we are using some of the patients right now. 2-3 of my patients are on misoprostol. Ulipristal previously I used to give. If you give ulipristal because of fulminant hepatotoxicity, you have to do LFT before starting, and probably every 3 months or so you have to do liver function test. Okay, don't want to take the risk, you can go for mifepristone. Usually 25 milligram dosage we are giving. Okay. So now, sir, we'll go to surgery, myomectomy.
The route of surgery is clear to all of you, the students. There is no difference of opinion about the route of surgery, laparoscopy or laparotomy. I think Dr. Habibullah has given you both the options, but you are authorized to make your own decision. If you ask me personally, I will not go for a laparoscopic myomectomy in this case, isn't it? Of course, it takes a lot of time. It takes 4 hours time to do the myomectomy when there's a lot of, uncertainties about particularly when you use GnRH agonists before the surgery, and then you take a prolonged operation with a prolonged morbidity, etc., etc. So that is you as a consultant, you can always say that, sir, I will prefer laparotomy. There is no problem about that, but you have to justify that. And the other thing is the question that should arise is the morcellation. After the procedure, morcellation is it's a difficult thing to accept. This in-bag morcellation is quite difficult, expensive, and not available in many centers. So I think that these are the two issues that can happen with the laparoscopy. So in the balance of judgment, you can always say that I'll go for a laparotomy, and no marks will be deducted for that. And
let us say we are doing open myomectomy, suprapubic, fan still incision given as the size of the fibroid has reduced. How will you reduce blood loss during surgery? We'll come to specific issues.
so we can use vasopressin.
Main worry is bleeding, isn't it? Especially if there are multiple fibroids. What consent you will take from this patient?
So, while doing the abdominal myomectomy, we should take the consent for hysterectomy.
In severe cases.
The patient should be counseled and explain about the risk.
And in extreme cases, sir, we can go for the hysterectomy.
See, in my whole life, in the last 40 years, I have seen only 1 or 2 patients undergoing hysterectomy, that too by my professor, for a VIP. That's all. Though we take consent, is extremely rare.
Sir, of recurrence, sir, and blood loss.
Blood loss, yes.
So you have to see that patient is having adequate hemoglobin, not less than 10 grams. Don't operate premenstrually or immediately after menstruation. Okay. Each point is important. So intraoperatively, how do you reduce blood loss now? Techniques used intraoperatively.
So we can divide it into pharmacological or mechanical. In pharmacological, we can use vasopressin.
How much? How do you use vasopressin?
So we use it, inject it, sir, intramyometrial into the site of incision.
Direct vasopressin you will inject?
No, sir, we'll
dilute it. In
what dilution? How many units? Tell, please. That's what I'm asking.
The 20 units in 100 ml NS. So 20 units in 100 ml NS.
At least 100 ml. I have seen people using in 200 ml also. Minimum 100 ml. 20 units in 100 ml.
100
ml.
Okay, tell the anesthetist that you are going to inject. Sometimes it goes intravasation, BP may shoot up. Okay. Okay. What are the principles of myomectomy? So if you are saying mechanical method, what mechanical method? We are not using nowadays, but since you told that.
Tourniquet, sir, tourniquet. We
Tourniquet,
can use tourniquet on uterine artery.
how do you do that? How do you tie tourniquet?
So by Boney's clamp.
You are saying tourniquet now, you're shifting it to Boney's clamp. I am asking about tourniquet now.
So
That is asking how do you apply tourniquet?
Make a hole in the broad ligament lateral to uterine vessels on either side.
yes,
Pass a red rubber catheter and tie it at that level, isthmus level.
At the level of
Okay. If you don't want to do that, you can apply Boney's myomectomy clamp.
Boney's
When you do
clamp.
that, include both the round ligaments so that it will not keep on moving. Okay. Does it stop the blood supply to the myoma completely? Or you should have to do something else?
so if it does not stop, then we can go for uterine artery.
No. There is a
Utero-ovarian ligaments, we can tie the utero-ovarian ligaments.
ovarian ligament. That means fallopian tube also gets ligated there. Infundibulopelvic ligament. Ovarian vessels, you have to apply a guarded ring forceps or sponge holding forceps with rubber coverings. You have to occlude. About half an hour, you have to release both myomectomy, Boney's clamp and these clamps every half an hour or so if it's getting prolonged. Okay. Finally, before closing, remove and wait and see for bleeding. Then, okay, then how do you do myomectomy? What are the principles of myomectomy? Start with single midline anterior incision.
Your voice is not coming, Shweta.
Are you answering?
Unmute now.
You are mute.
Where is Shweta?
Shweta, you unmute, please.
Sure.
Admin can unmute. Yeah. Now you answer. No. I told already incision, anterior incision, single midline, enucleate if there are fibroids in that line. Through that, you can give secondary tunneling incisions and to remove other fibroids. Suppose there is a single large posterior wall fibroid, what will you do? Not audible.
तुम्हारी आवाज नहीं आ रही. Just check.
Yes. Have you heard of Boney hood operation?
Try to speak now. Rupal. Try to log in with a different device, please. Log in with your mobile. So Dr. Rupal, if you have logged in, please switch on your video. Unmute yourself, please, and start answering. Sir was asking about principles of myomectomy.
Unmute.
Unmute karo, why you are wasting time? Bolo? We request the host to kindly unmute them. They are unable to unmute themselves.
मैम कौन से नाम से ज्वाइन हुए हैं?
ये रूपल के नाम से.
एक सेकंड. श्वेता एंड रूपल, डॉक्टर श्वेता एंड रूपल.
हाँ, अपना वीडियो ऑन करो रूपल. Then only she will be able to identify you. Yes.
I think they are unmuted now.
Yes.
देखो बोल के देखो श्वेता. Try to speak. तुम बोलो तो सही, कुछ आवाज आएगी इधर. So log in with your phone. Why you are coming to this device again?
Can we ask Dr. Preeti Singh and the other somebody else are also there? No, for the next case, shall we ask them? Because they are not answering. They are not. We are not able to hear them. Dr. Preeti, can you
Yes,
tell?
sir.
Can you tell the principles of myomectomy, which I told already some of them? You are only prepared for hysterectomy, not myomectomy.
We only ask them to do so, sir.
Do you know what is Bonnie Hood operation, which I was telling just now? Sweta and Rupa are there?
Yes, sir.
Switch off the other devices. If you switch off the other devices, there won't be echoing. Only keep one device on. Okay, now you tell. What is Bonnie Hood operation?
The Boney Hood operation it is used to remove a large fundal fibroid. A low transverse incision
Fundal or
made-
posterior wall fibroid also.
Yes, sir.
Okay,
A low transverse.
we don't want to give the incision and the posterior wall of the uterus. Why?
Sir, due to scar rupture or
Before scar rupture.
Adhesion, sir.
Adhesions in the posterior wall will cause more infertility. We are doing, infertile patient myomectomy. So there can be adhesions, intestines, omentum, anything can get adherent in the posterior wall. And to avoid that, we don't like to give posterior wall incision. And afterwards, when she becomes pregnant, if there is incision in the posterior wall, you can't detect impending scar rupture. Okay? Scar
Yes,
cancer and all that you can't elicit in that case. So, okay. So anterior midline incision, single myomectomy you do, and through that tunneling incisions you give, remove the other fibroids. Okay? And start from the bottom of the deficit, you start closing by concentric rings. Okay? Vicryl, you can use delayed absorbable and close the incision. And at the end, make the uterus antivated by plicating around ligaments. Okay?
Yes, sir.
Yes.
Give hemostasis. And if there is a polyp, how will you remove? Not in this case. If there is a cervical polyp, what are the techniques to remove polyp, fibroid polyp? Polypectomy, what you call, okay? What are the methods? Unmute and tell. You are muted still.
Sir, hysteroscopic polypectomy can be done, or with
You see, polyp is hanging from the cervix outside into the vagina. How will you remove?
sir, with the help of the sponge holding forceps with the blunt force, we can twist the polyp and then can remove it.
So for all polyps is not same treatment. If the pedicle is thin, very thin, then only you will be able to hold with the sponge holding forceps. That is called avulsion of the polyp. Okay. Next, if pedicle is thick, reachable, you put a clamp and cut. Excision you can do. Avulsion and excision. Number 3, if the fibroid is this big, hanging, it has got extruded outside. You won't feel the pedicle. In that case, give the incision close to cervix all around in the capsule. Enucleate the fibroid. Remove the fibroid. Okay, myomectomy, enucleation you do. only capsule will be left then. Then you will be able to see the pedicule. Okay, 3 methods: avulsion, enucleation, and excision. All the three. Then, of course, if it's inside it's submucous fibroid, that what you said, hysteroscopy. Sir?
Yes.
Ashish sir, you want to ask anything with this?
No, actually, we want to shift to the second case.
Yes.
I think the myomectomy you have described to them in detail. What are the principles of myomectomy they should know? What are the incision planning? What are they going to do? How are they going to approach the myoma and transcavitary approach the Bonnie's root? These are the things they should know in an open case.
Operation note very important. If you entered the cavity, it should be made clearly mentioned on the top of the front of the case sheet. It should be mentioned in patient becomes pregnant next time elective cesarean section should be done. It should be written clearly. Don't write in the operation note myomectomy done by 10 fibroids removed.
Yeah.
No use. Okay.
So that these are the important messages. With that, I close this case because we have to go to the second case, and then we have to have a lot of discussions on other things. Thank you very much.
Thank you.
Dr.
Thank you,
Sheila
sir.
Jamal and Dr. I can hardly see them, but they have done a wonderful job. But remember that whenever you present a case of adolescent myoma or an unmarried girl, you need to be doubly careful about the points that we have discussed. About the diagnosis, you need to be very careful because you don't have much avenues for the diagnosis. You have the disadvantage of not having a transvaginal sonography or a PV examination reports. So the important differentiating points between the other things by ultrasound, abdominal ultrasound, you should know. So I close this case and I will welcome the second case and the presenting doctor, Sir Dr. Preeti Singh, right? From IMS Varanasi and ably guided by Dr. Sangeeta Rai, I think. So I will request thank you very much. Dr. Habibullah, you can stay back in the second case also. You are most welcome for passing any comment. Thank you so much.
Thank you.
Yes, Dr. Sheila Jamal, thank you very much for guiding your students very well. And we would now like to welcome Dr. Preeti Singh to present the second case. Preeti, please share your screen.
Yes, sir.
Go from the first slide and then go into slideshow.
Yes.
One of the few comments that interested me is that if it is a 20 in the last case, first case, if it is a 20
Good
week,
afternoon, respected teachers. Today we are going to present a case presentation on abnormal uterine bleeding in perimenopausal women.
Dr.
Preeti, hold please.
Just one second. In the last case, we got a
My
comment.
patient, Mrs. X, 24 years
Not
of
being able
age,
to hear.
housewife by
Can you
occupation,
hear me?
married.
She's very focused. Yeah, 1 second, Preeti. We just wanted to tell you that in the last case, somebody
Sir, we are
commented.
not able to listen.
They are not able to hear you.
listen and
Okay. Leave it. We will do it in the end. Okay.
Are
Preeti,
you able to hear us? Dr. Preeti? Can you hear me?
surprising thing, the younger generation having more problems in computer handling than the older ones.
Yes, sir. What happened, Preeti?
Older, please don't say, sir. Not so young, you can say.
Not so younger. Yes, yes. I agree with you, sir. I
Why
also
you
get
think
upset
that?
when someone tells me old.
Can you hear us, Preeti?
Something is wrong in their system. We can hear them, but they cannot hear us. Admin, please look into it. We have limited time now.
Hello, Dr. Preeti. हेलो मैम, आपको मेरा वॉइस आ रहा है क्या? हेलो डॉक्टर प्रीति. हेलो. सर उनके नेटवर्क में शायद कोई प्रॉब्लम है।
हाँ, इनका सिस्टम में प्रॉब्लम है।
हाँ सर, क्योंकि आपका वॉइस और मेरा वॉइस आ रहा है क्लियर, उनका वॉइस
Yeah,
नहीं आ
yeah.
रहा है।
Even we can hear them clearly, but they can't hear us.
Hello.
Seems like a typical exam situation. Seems like a typical exam situation. The examiners can hear the students, and the students cannot hear the examiners.
No. ఆశీష్ తర్వాత లాస్ట్ మాట్లాడలే ఆయన ఇదైపోయాడు.
Yes, ma'am. They are not able to listen.
తెలియదు, నాకు తెలియదు.
No, ma'am.
శీల ఏదో ఉంది, ఆవిడ అసలు మాట్లాడమే ప్రాక్టీస్ ఉన్నారు అసలు.
Okay, ma'am. Okay, ma'am.
జమాల్ అని అందులో
Login again. Leave it and login again.
చాలా చెప్ప స్టూడెంట్స్ ఏమీ చెప్పాను వెళ్ళిపోయారు, అక్కడికి వెళ్తున్నామండి. మాది వద్దామండి వెళ్ళిపోయింది 10:30 నేను మాట్లాడుతున్నప్పుడు అది లాస్ట్ చెట్టు పడేసి దీనిలో కూడా ఉండమన్నాను, ఆయన ఉండమని చెప్పాడు. ఆయన నాకు చెప్పడం ఈ కేసు అయ్యాను. నీకు అట్టి మామిడి పండు కావాలా? రాణి గారు ఇచ్చారు, అప్పుడు ఇస్తాను. వస్తావు, ఇక్కడికి రావాలా నువ్వు? నేను అక్కడికి వస్తే అలాగే నేను 6:30కి అలా వస్తాను, ఎందుకంటే మా సార్ ఉంటే 5:30కి వస్తాను అనుకుంటున్నాను. ఓకే సరే.
Now you can hear me. Preeti and Garima, can you hear me? Hello.
No, ma'am. Yes, ma'am.
हाँ यस मैम, पहले आ रही थी आवाज।
एक काम करो ना, मोबाइल से लॉगिन करो।
Yes, ma'am.
Start and somebody must start join radio mobile. You can hear us.
Ma'am, we are joining with mobile. Yes, ma'am.
Yes, now you are audible. You are audible. You can start again.
Yes, ma'am. I'm joining from mobile. Yes, ma'am.
Pity, you can start now. You are audible now.
Hello.
Please share your screen.
Recording in progress.
Hello.
Yes, ma'am. I have joined from mobile and it's showing that the host will allow us.
क्या नाम से ज्वाइन किया है मैम?
Yeah, maybe the problem is continuing. I think Dr. Sangeeta, can you go ahead with this case if they cannot join or if they cannot hear? Or you can take help from another person.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Okay, ma'am.
So are we audible?
Yes, ma'am. We are
Okay.
able to hear
Start the
now.
presentation.
Yes.
No, they are audible, but then they cannot hear us. So how can they respond to the crossing?
Sir,
And
they can hear us. ma'am.
Now we are able to hear, ma'am.
So they can hear us now.
Yes, ma'am. Now we are able to hear, ma'am.
okay, then go ahead with the presentation. We are wasting time.
Yes. Good afternoon, respected teachers. Today we are here to present a case on abnormal uterine bleeding in perimenopausal women. My patient, Mrs. X, 44 years of age, housewife by occupation, married. She is Varanasi, Hindu by religion. She admitted on 28th May 2023 and examined on 21st May 2023. Her socio-economic history, she is resident of Varanasi. Her husband education is up to graduation. She studied up to class 10. Husband occupation is shopkeeper. Monthly family income is 15,000. Environmental sanitation and potable water was good. Socioeconomic status of the patient according to Kukuswamy scale is lower middle class. Chief complaint, she presented here with a complaint of heavy menstrual bleeding for 2 years, PV discharge on and off for 6 months, lump in the abdomen for 4 months. History of present illness, she presented with complaint of heavy menstrual bleeding for 2 years associated with passage of clots, not associated with dysmenorrhea. She also complains of painless lump in her abdomen for 4 months. Later on, there was increase in pain. She also complains of increased frequency of menstruation for 2 months. Menstrual history, she attended menarche at the age of 30 and flow was heavy. Duration of the menstruation is 6 to 10 days, stops only on medication, regular, associated with passage of clots, not associated with dysmenorrhea. She used 4 pads per day. Her LMP was 15th of May 2023. Obstetric history, she is para to life 2. Maternal history, both of the delivery event and pregnancy event was uneventful. One was in 2008 and second was in 2010. Both the pregnancy method of delivery was LSCS. Both baby are doing well. One is male and second baby is female.
Sir, sir, can I say something?
Yes, yes, yes.
Go back history, obstetric history. So suppose somebody has 4 deliveries. First mentioning about all the pregnancy complication delivery, then next table, first baby alive, healthy, second baby, difficult to correlate both. In the same slide, you should give outcome of perinatal outcome in last column, I feel.
Actually, this is not the format that we get in standard textbooks, right? In standard textbook, we have a definite format. I asked you to go into that format and just fill in the forms tag and place it over here. What you have done, you have made your own columns.
No, you sent this format, ICOG format, but this is not done by any other textbook. Textbook says after puerperium, you have to say the perinatal outcome. How is the baby doing? What are the the same thing, not separately. Very difficult to remember. Now, first baby, what happened? You are telling in another slide. Second baby, third baby. Somebody has recurrent pregnancy loss. Then it becomes very difficult.
No, in the same slide, it can be it can be done.
Last column. Okay, thank you. Go ahead. Go ahead.
Coming to the past history, her past medical history, no history of diabetes mellitus, hypertension or thyroid disorder. Surgical history, history of 2 LACS in 2008 and 2010. Bilateral tubal ligation done with second LACS. 8-month FOGSI presented.
Sir, we also don't mention diabetes, hypertension in the past history. That means right now she doesn't have?
No.
Past history, surgery or something, she had a hernia repair, something that is past, but now she is having diabetes. So in the history of present illness, last sentence should be, she is the known case of diabetes and hypertension on this treatment. You have to tell in the history of present illness. Okay?
I don't think
it's not a past history.
And I don't think cesarean section needs to be mentioned again in surgical history as well. It's already there in obstetrics.
Yes. In the there itself, you should have said along with cesarean section, she had sterilization operation. There is no need to mention separately here. And new symptom lump patient cannot say. You can say swelling or distension, that only you should say. Lump is what you feel, a mass, what you are examining and you find it, that is a lump. Okay, your new symptom is only swelling or distension. Okay.
Similarly, if this is history, then I don't think patient would have said she has undergone endometrial sampling unless the patient is an educated patient. She's just 10th pass, right? She must have told you that some report was done and some sampling was sent. So if you are just writing the words of the patient, then interpretation you would say, okay, that must be some endometrial sampling or DNC must have been done, and the reports as per the history given by patient is such so and so.
In medical history, I would also like to mention that the coagulopathies have to be asked.
Yes.
Okay, madam. So how do you suggest, what are the questions they should frame? Dr. Poonam Mathur.
Yeah. Because they normally in the fibroid uterus, what are the complaints, Preeti?
It's really heavy menstrual bleeding and heaviness in the lower abdomen.
Yeah. So according to classification now, if we say that this is due to the coagulopathy, then what questions will we ask?
There might be mucosal bleeding or bleeding on trivial falls, ma'am, and there might be history of epistaxis or bleeding.
Other organ bleeding might be present in coagulopathies, ma'am, not the heavy menstrual. So relating to each complaint, one is the distension. So related to distension, in view of the lump, we have to, in view of the fibroid, we have to ask the different questions. And like in heavy menstrual bleeding, it can be from anywhere. So we have to be very specific about the complaints to locate what the cause is.
Yes.
What is the classification for abnormal uterine bleeding?
Palm coins. AOP is polyp, ma'am.
And if it is due to coagulopathy, then?
AOP C, ma'am.
Yes. Please go on.
Let them complete the history and then we will go into the crossing. Okay.
Okay.
So students, how many slides left now with you? Go ahead.
Oh, okay. 8 months back, she presented with heavy menstrual bleeding, for which endometrial sampling done. After the result of histopathology that was proliferative, she put on medroxyprogesterone acetate, but symptoms not improved, and she presented again in OPD in May with a new symptoms of lump in abdomen along with heavy menstrual bleeding. Family history, no family history of twin, tuberculosis, diabetes, hypertension, and asthma. No history of malignancy in first or second degree relative, mainly colon, endometrial, or breast cancer.
And again, I would like to tell you that in a case when you are presenting a gynae case, especially fibroid, then a twin need not be included in family history. Definitely, when we are using it in as an antenatal case, we do use this, right?
Yeah, there are many ways of taking their family history, and these things you may write in the sheet, but while you're saying,
You
need
may
to be
not,
selective
yes.
about
Exactly, relevant things.
that is why the summary writing is so important, and which one to say, which one not to say. There will be a format in which they will write.
Unnecessary troubles you are inviting by you saying things which are not
Yeah, there are
relevant.
many examiners who will pick up this issue
Yes.
and say, how does the twin history reflect
Yes.
in the myoma in the patient in the
So
next?
you might be in a soup by saying something which is not needed.
So the suggestion will be you can write it in your case sheet, which will be taken away by the examiner. And then while saying that, you can say, you may omit this, some of the things. Even almost all the this thing format you'll see in the history, most of them, they need not be said in the case presentation summary. Yeah, go
But,
ahead.
family history of fibroid in the first degree relatives.
Yeah.
That can be asked.
To replace twin by a fibroid.
Yes.
Okay, students should note that. No history of allergy to any drug you meant, not addicted to any substance. Okay. Okay.
Drug history, she is presently on medroxyprogesterone acetate. Functional history, her appetite is good, bowel habits normal, bladder habits increased frequency of maturation for 2 months, sleep cycle was normal. Nutritional and dietary history,
Did
she
she
is
present
vegetarian.
this bladder symptom, did she present in the chief complaints? Did you write it in the chief complaint? I'm sorry,
Yes.
I missed the first part. You didn't know.
Yes, sir.
She's suffering from last 2 months. Probably she could present it in the chief complaints.
Yes, sir.
Okay. Okay. You should check all these things.
Nutritional and dietary history, she is vegetarian. After calculation on the basis of 24-hour recall method, she takes 2000 kilocalorie per day.
2000 kilocalorie per day. Okay.
Next part will be presented by Dr.
Good afternoon, respected teachers. Coming on to general examination of this patient. Examination is done in well-lit room and patient is alert and cooperative. She is of average build. Severe pallor is present. She is normovolumic with pulse rate of 94 beats per minute. Her BP is 120/80 mm of mercury with BMI of 26 kgs per meter square. Icterus cyanosis clubbing is absent. Pedal edema absent.
Excuse me. You have said, beta, that severe pallor. So if the pallor is severe, I would rather suggest you also may add that clinically her HB looks like this, because you have said severe. If it was mild or something, it still can be omitted. But when it is severe pallor, you better specify, because that's quite a vague term. And severe, I would understand, is somewhere below 4 or 5. So better you specify something if you are writing severe pallor. Okay.
Yes, ma'am. She is pale looking and
very good. But how much do you look? How by the look of the patient, what do you think her clinical HP is around what?
Around 6 to 7.
Around 6.
Around 6. Around 6 to 7.
if it is 6 and you are writing severe pallor, that is why my interpretation of severe pallor would be that we are not going by mild, moderate, severe anemia, and you are using the word pallor. So that is why you may specify a clinical HB looks like this, because I would say okay, it is less than 4-5, right? Because pallor is severe. Okay, continue.
Pedal edema absent, necklines were not palpable. Coming on to local examination, bilateral breast grossly normal, no engorgement, no palpable lump, and no discharge present from bilateral breast. Coming to systemic examination, CNS, higher mental functions intact, CVS, S1, S2 heard, no murmur present. Respiratory system, bilateral vestibular breath sounds heard, bilateral chest clear. Per abdomen examination, on inspection, abdomen is enlarged up to the level of umbilicus. Umbilicus is centrally placed and inverted. No superficial pulsation or visible peristalsis seen. No dilated vein or venous engorgement. Vertical scama present from pubic symphysis to umbilicus corresponding to previous cesarean section present. On per speculum examination, vagina grossly normal and pink, cervix hypertrophic, there is copious mucoid discharge present. On palpation, uterus is uniformly enlarged up to 26 week size, mass of approx 15 into 16 centimeter in size, firm in consistency, non-tender, with smooth surface, non-vacillated, with regular margins, with no groove sign. The lower margin of the mass is not raised.
What is this palpation? After speculum examination, you are saying palpation. This is abdominal palpation you are telling now, after speculum examination.
First, we will do inspection and then palpation. Yes, sir. Then we'll do per speculum examination.
Okay.
Yeah.
Coming on to per vaginal examination, uterus is uniformly enlarged, 26 week size, non-tender, groove sign absent, mobility is slightly restricted, bilateral fornices free and non-tender, PODs was cleared.
See, bimanual examination, you can't assess the size of the uterus as 26 weeks. Up to 12 to 14 weeks, when you do bimanual, you can say it is this much. Beyond that, you can say the size of confirm. That's all you won't say about the size in PV.
Yes.
Abdominal size 26 weeks. How do you know by bimanual examination is 26 weeks? You can't say.
Yes.
Okay.
Sir, on per abdominal examination.
No, is there any mass when you do PV by the side of the cervix or by the side of the uterus? Then only you can say. If there is a mass, then you say there is a groove between the two or not. When there is no mass at all felt in bimanual examination from below, how can you say groove sign is absent?
Sir.
Understood?
Yes, sir.
More than that, when we move the abdominal mass, the movement is transmitted to the cervix. That's what you should tell here.
Yes, exactly.
Okay.
Yes.
All of you agree with me, I suppose.
Yes.
I made this point even in the previous case. You have not heard previous case? Okay. Right, go ahead. POD was clear, you don't say. Fornices 3, that's what we say. That means no adnexal mass is felt enough. Separate all fornices. Posterior fornix also, POD includes posterior fornix also, isn't it?
Yes. Coming to summary, my patient X, 44 years old, para to live to, both LSCS, housewife, from lower middle socioeconomic status, was admitted with chief complaints of heavy menstrual bleeding and lump in lower abdomen for 4 months. Her cycles were regular, but it lasts for 10 days. On examination, her vitals were stable, but severe pallor was present. She is pale looking. On per abdominal examination, there is lower abdominal swelling situated in midline, most globular, firm in consistency, extending up to umbilicus. Margin is well defined, except lower border of the margin couldn't be reached The surface was smooth and dull on percussion. On her vaginal examination revealed a mass of size 26 weeks uterus extending up to umbilicus. Coming to
no, keep it on the summary itself. See, just go through the sample summary that I have presented. Here also, you have started the summary, and then a cycle was regular, but it lasts for 10 days. And then you jumped into the examination. What about the summary of other histories and the general examination, etc., etc.? So everything you should write in detail. Summary is not that simple. What are you trying to say? Summary, you cannot skip certain things and jump into the examination.
And especially when
summary, you have to say all the even important negative histories are to be mentioned here in summary. The summary is the most important thing which you say in response to the question by the examiner, what is your case? So prepare it comprehensively. Okay.
I would like to add that especially when it is a case of perimenopausal bleeding and you are thinking of fibroid uterus, then the summary of the cycle was regular and lasts for 10 days. The bleeding thing needs to be elaborated a little more, because most of the time, especially in this type of case, when it is a perimenopausal case, our choice of management options would depend upon the type of bleeding. Say if it is lasts for 10 days, but it is spotting, it could be something different. And if it is 10 days and all the 10 days he's bleeding heavily with clots, then the management could be something different, right? So a little elaboration here is required.
When do you say that this is heavy menstrual bleeding? Because this is subjective, you know, the number of pads she is taking. So whether she's having heavy menstrual bleeding?
Yes, ma'am. It's associated with passage of clots, and she used
normally in the normal menstrual blood, why the clots are not present?
Clots are present, ma'am, but
they are
that
are they? The normal menstrual blood.
What happens to the clots? Or rather, how is the clots formed in excessive bleeding? You must know the genesis of the clots. Clots always suggest heavy bleeding. Why?
Why?
Because of the intrinsic fibrinolytic mechanism inside the uterus, clots never form in the uterus. So when the supply of the blood is more than the storage capacity in the vagina, then only the clots happen. That means supply is in excess, storage capacity is limited, and therefore the clots form. So always clots will suggest heavy bleeding.
Also, now as per the recent guidelines, we need to, when madam asks you about heavy menstrual bleeding, you have to include the word quality of life. So as per the new guidelines and the definitions of heavy menstrual bleeding, we have to take into account any amount of bleeding which is affecting the quality of life of a patient has to be considered as heavy menstrual bleeding. Their quality of life dependency could be different for different professions as well. So we have to take care of that as well. Okay?
So definition in terms of QOL, you mean, isn't it?
Yeah, at least they should be. I mean, if suppose a woman is an athlete and she is bleeding, so we have to intervene a little earlier, maybe. Means any amount of bleeding when it interferes, these definitions are so quality of life needs to be included in all the matters.
Yeah, point well taken. Just like in PPH, we have modified the definition. Similarly, you have to see blood loss is a very subjective phenomenon, as Madam has said, Dr. Poonam has said. So it's a very subjective phenomenon, and doctors are actually notorious for underestimating blood loss. In PPH also, in menstrual blood loss also, and the patients are over anxious about the blood loss. And the soakage of pad is always a very tricky subject for me, because soakage of pad doesn't mean anything. Some people throw the pad, half soaked pad or quarter soaked pad by a drop of a hat. Well, some people wait till it's fully wet and it spoils the undergarments or something like that. So I think the subjective element of blood loss has to be balanced with some objective finding.
And
be it in the form of your change in the lifestyle, QOL, or it can be in the systemic disturbances, or it can be in the anemia, like the blood.
Or it can be, one point I want to add, or it can be more than what they used to breathe earlier.
Yeah,
That
exactly.
is very important because some patients bleed heavily all through their life. It is their tendency. So if more than that they are having, then it has to be considered heavy. But if they were having earlier just 2 or 3 days and very light, and now it is 5 days and all 5 days they are heavily, then has to be considered
If
heavy.
you have to take into consideration that it need to be very, very detailed. More than previous means what? Previously it was 8 days, now it is 10 days, something
Whatever.
like that. So
Whatever,
I
yes.
think, and then you have to be very, very detailed in this analysis. But I think a better way is that it is your idea. When the examiner is taking your statement as accepted, you must justify when needed that this is a heavy menstrual blood loss. So we are going back to the basics now. Come to the this thing last. What is your diagnosis now? And the summary, I think you should rewrite because summary is not covering all the points clearly, right? So everything you must be, short yet comprehensive.
In fact, the fact of previous 2 LSCs is also not written here in the summary, whereas in the treatment modality, it's very important in this patient. So that needs to be mentioned.
Both LSCs, it's
They have
mentioned.
written, both LSCs, they have written.
Okay.
Para to life.
Sorry, I missed. I have not seen. Sorry, I missed.
Okay. Chalo, next, go to the next slide, please.
Coming to my provisional diagnosis, my patient X, 44 years old, para to life 2 with previous 2 LSCs with AUBL.
My patient, delete the term my patient. Everything is your patient. So Mrs. X, 44 years, para to life 2 with previous 2 LSCs with AUBL. Okay, chalega. Okay, AUBL. Next.
Now go to the previous slide in the differential diagnosis. Yeah.
My differentials are, it might be AUBL, AUBA or AUBM, or we can include ovarian tumors also. But we have to go for further workout to rule out.
Why have you written AUBA and AUB? M तो चलो ठीक है AUBA क्यों लिखा समझ में नहीं आ रहा है
The uterus size.
So yes, in AUBA, the size of uterus is doesn't cross 16 weeks. It's 12 to 14 week size in adenomyosis, and it's associated with dysmenorrhea. Here, the patient doesn't have dysmenorrhea, and uterus is of 26 week size. So we can rule out it's the points in favor of AUBA are very less. So I'll rule out AUBA from my DD.
Does the patient of fibroid have pain as a complaint?
Sir, ma'am, fibroids may be associated with pain, but it's not the chief complaint.
No. Here you are wrong. Many times it can be a chief complaint of pain. What
spasmodic?
Yes, you can say what type of pain in adenomyosis.
In AUBA, they usually complain with congestive type of pain, ma'am, and AUBL pain is spasmodic.
Spasmodic, okay, not always, but yes, then there can be bulk pain as well. Because
yes,
of the pipe, yes, it can be.
Which type of myoma will cause more pain?
What is the first line there?
Intramural.
In differential diagnosis, why do you write this first line? My patient Mrs. X 44 year with previous to LSCS with. What is this?
And also L you are already saying no in provisional diagnosis. So in differential it should not come.
Okay.
So delete the first line, delete the second line.
And third line as well.
No, okay. They are trying to keep adenomyosis there and the M there. Okay, then so how do you differentiate? What are the investigations? We'll quickly go into the treatment now because I wanted to have a discussion on hysterectomy. So yes, remove this. And what are the investigations you would like to propose now? For
Sir,
this?
first, my patient is pale looking. I'll go for CBC to look for the hemoglobin levels, and then I'll go with
coagulation profile, ma'am, and transvaginal sonography, ma'am.
Okay.
And ma'am, as we are keeping one of the DD as AUBM, we'll
Tumor
also
markers
markers also
and
CA125 levels.
Okay. But in your differential diagnosis, you have never brought this thing of ovarian tumor or something like
Yes,
that. Have you? Have you done that?
Yes, sir. There is one of the DD might be ovarian tumors, but as in my examination, pouch of the bilateral fornices are clear and there is no groove sign present. So points in favor of ovarian tumors are less. So I'm ruling out ovarian tumors from my DD.
Will you not rule out pregnancy?
Ma'am, she's having regular periods.
There can be cyclical residual bleeding. We had a case who regularly had menses every month, and there was a pregnancy. She came with pains. So then you have to rule it.
Okay, ma'am.
Okay, so after the supportive diagnosis modalities, now anything else you want to confirm your diagnosis? You have mentioned about ultrasound, you have mentioned about TVS, you have mentioned about the blood count. Any other thing that you want to examine? I mean, investigate?
Maybe something which might be even helpful for deciding to what line of management you want to go.
Deciding the line.
Pardon?
We have
didn't
discussed,
hear.
we have discussed about the MRI, the fibroid mapping and things in the previous case. So we won't discuss it here. Well, I'll go straight away into the treatment. Now tell me, what is your operative decision that you have taken in this case and counsel the woman? Would you like to go for any medical management?
It's the size of the mass is very large and she is bleeding heavily. We already put her on medical management 8 months back. So this time we will directly the surgical management.
Okay, so enough is enough. You have stopped now medical management. Okay. So what surgical management would you like to propose to the woman?
Total
Dr. Hemkanta Sharma wants to be unmuted. Admin, please help him. Dr. Hemkanta Sharma, you want to say something after you get unmuted? Yes, bolo.
So we'll go with total abdominal hysterectomy. As a patient is previous to LSCS and the size of mass is 26 weeks size.
Right.
Yes. And she's perimenopausal. She's
Dr.
previous to
Hemkanta, would you like
LSCS.
to say something? Yeah.
No, okay, okay. No, it was accidentally unmuted. That's why I told you. Okay, I'm listening.
Hello.
Okay, please continue. Please continue. Please continue. Okay.
Well, he can't
So
hear.
as-
Okay, fine. So yes, you will go for the abdominal hysterectomy, right? You surely
Yes,
won't
sir.
go into vaginal. Okay. With anything and now about the principles of myomectomy, we have already discussed, and we won't discuss about myomectomy here. So we're in the hysterectomy. So what are the different avenues of hysterectomy? Different.
So just a point. I would like to ask
Unmute
you
yourself,
when-
Dr. Nalini.
Sir, I'm unmuted. Hello, am I
Yeah,
audible?
we can hear
Yes,
you.
ma'am.
Dr. Poonam, Dr. Nalini, we can't hear you.
We can hear it.
Yeah. Okay, now. Okay, now.
Okay, so I just want to ask you, beta, there are people in which this type of 26 fibroid, when they go for a hysterectomy, they did not directly go for hysterectomy, they go do a myomectomy first. What is your view upon that? Is that a better option or not?
As the age of the patient, she is perimenopausal, ma'am.
No, I'm not saying that. While doing abdominal hysterectomy, will you remove the specimen intact, or you are going to perform myomectomy and then do hysterectomy of the same thing?
We'll remove in one go.
Very good, very good. Good. But why? Why? Do you know that it is,
If we
always?
do myomectomy, ma'am, then the blood loss will be more.
Very good. Very good, very good. Fine. Because
but-
I've seen people doing that. That's what I was doing this type of.
What is the purpose of doing that two-stage operation, madam? Dr.
No,
Nalini?
no purpose. But I have seen people doing that. That's why I asked. It's not that in your. It's clear with them, na? It's not to be done. Just ask them.
Yes.
Okay, so you will go for what did you say? Students, what did you say, Preeti?
In one go only.
So
Will
total abdominal hysterectomies.
will not remove fibroid separately. Will remove it along with uterus.
Okay, fine. Now, suppose the uterus, this is a quite big in uterus. I mean, 26-week uterus. I think even most of the laparoscopic surgeons will, will not go for the laparoscopic hysterectomy, because that will end up in the end, the question will remain how to deliver this uterus, and then they have to do the morcellation and all those things. So abdominal route will be preferred, abdominal hysterectomy. So you'll be asked now about the steps of abdominal hysterectomy. And I believe all of you are absolutely
Then
aware.
first more question, Beta. It's previous to LSCS and the scar are both transverse. So which incision are you going to keep in 26 weeks uterus for doing hysterectomy in this case?
Will go with vertical incision, because to deliver the uterus outside, it will be easier with vertical incision if uterus is up to 26 weeks size.
Here I would say, okay, if the uterus, it is a single fibroid, 26 weeks, then fine. But sometimes there are multiple fibroids. Even when the uterus is 26 weeks, you might as well deliver the uterus in transverse. Looking upon the anatomy, we have to finalize, but more or less 26 weeks, mostly, yes, definitely, paramedian or vertical incision is a better option.
Apart from that, Madam Dr. Nalini, there could be disadvantages of having two previous cesarean sections with.
Yes, so there will be radiation.
And there will be difficulty in taking out the uterus in the transverse incision. So it is not just cosmetic matter of excluding those vertical incision. It is also ease of access and ease of delivery of the uterus. That also we have to take care of. Yes, students, so you'll go for a vertical incision, agreed with that. And then you will have, what are the steps of the abdominal hysterectomy? And preserve the ovaries.
After giving incision, will separate rectus muscle from rectus sheath, and then after entering abdominal cavity, will deliver uterus out, and then first will clamp round ligament, ovarian ligament, and fallopian tube to both sides, and then will ligate and cut, then transfix and cut level 1, and level 2 is uterine artery, level 3 is uterosacral ligament. And then after clamping, transfixing, and cutting, will
You have not mentioned anything about after ovarian level 1. Here about the tube, the fallopian
ovarian ligament. We mentioned ovarian ligament, fallopian tube, and round ligament, level 1. And level 2, bilateral uterine artery, and level 3 is uterosacral ligament.
Are you going to remove the ovaries, ovarian ligament?
No, ma'am.
No, ma'am.
Then what is the status? What about the tubes?
The fallopian tubes. Yes, they have said fallopian tube, the mesosalpinx, and the
ovarian
ligament.
And,
that means you are preserving the ovaries. Now, important to level 2, what do you do, or rather before the level 2, what do you do with the bladder incision? Because in this case is a repeat cesarean, 2 cesarean sections.
Yes, sir.
How do you dissect the bladder down? It's very important to do that. You do it by blunt dissection, or you do by sharp dissection, or you'll go for with the gauges or this thing. What kind of dissection will you do? Prefer?
We'll go with the gauge and pushing down
with the push.
I believe sharp dissection is.
No, sharp dissection would be better.
Okay.
And that too from the sides, the sides will be free. So you have to approach from the sides.
The lateral approach.
That's the basic rule of surgery, that anyway, sharp dissection is always better than blunt dissection. But I have always seen the students thinking it otherwise, and what you think is when you are doing sharp, you might enter into bladder or somewhere or injure some major things. But if you are meticulous and you are proper knowing proper anatomy, sharp is always better.
The best thing is not to give them gauze pieces in these cases. How will you give traction to the uterus, such a big uterus? What is the method of giving traction?
So we can put myoma clamp.
Myoma clamp.
Sorry, so we can put that myoma screw.
Okay. Myoma screw.
And we can.
Even with that, it becomes difficult because it's such a big uterus, and it also becomes softer towards the end, and then it causes a lot of hemorrhage. But I believe that most important thing is the assistant has got a big role to play, cover with the mops, and then pull it manually. It's quite a difficult job to pull the uterus on the opposite side, but you have to do that. Instruments usually fail here. Okay, so for the uterine artery, uterine vessels rather, we have this precautionary measure that you dissect the bladder with sharp dissection adequately and push it down, okay, by sharp dissection. If you take this step, you are preventing 2 organs from damage. What are them?
One is bladder,
ureter.
The second is the ureter, which goes laterally and goes out like this, out of field, operating field. If you do not do that, bladder ka to pata nahi, ureter definitely damage karoge aap. Okay. So that is the before the stage 2 or other type 2, and then you go in the uterine vessels ligation, but it is mandatory to dissect the bladder down with sharp dissection before this. Okay, so that is about the open hysterectomy. Now suppose the uterus is a bit smaller and you are going for laparoscopic hysterectomy. Now tell us the steps. What do you do? Not this uterus, but a slightly bigger uterus, a 10-12 weeks uterus or something like that, maximum 10 to 12 weeks. How do you approach? How many ports? Where the optical port should be placed? Doing
infra. Sir, we place 4 ports. Sir, first port, infra-umbilical, sir, that is the optical. And 2 ports.
Infra-umbilical, if you put the optical port, then you will be at a loss after a big uterus. But if it is 6 to 8 week size uterus, then that much is okay. But here, the incision must be placed at least 1 inch above the umbilicus, because your scope length is fixed. So you won't be able to reach with your side instruments and the port also. Dr. Hemkant, would you like to say something? You have been unmuted.
No, it's okay. No, now it is okay.
Okay,
I will say other words. Please continue.
I want to ask you if the uterus is, let us have a little discussion about the other treatment modalities. If the size of the uterus is not this big and it is the same perimenopausal patient with previous 2 LSCs, do you have anything else in your mind? Like we have discussed the treatment modalities in an unmarried woman, right? And now we are discussing in perimenopausal, but because of the size, we have omitted few of treatment options. Okay, so now if we think that everything remains the same, but
I want to discuss different ways of hysterectomy. Okay, like LVH also you can say, TLH you can say, abdominal hysterectomy we have discussed.
Non-descent vaginal can be an option in this
not in this case, but maybe in other cases you can go for non-descent vaginal hysterectomy. NDVH also you can. बेटा आप लोग वो कर लो, क्या कहते हैं उसको, skin share omit कर लो. We can discuss.
So other treatment modalities, any idea, beta? What are the things in perimenopausal we can use? So we can discuss about them as well.
Yeah. If the uterus size is not that big and if it is less than 12 weeks, we can go with medical management also.
With medical management here, like we let us not repeat the medical management which we have discussed in unmarried women, right? So to save time, I'm saying, right? So like I give you an please, yes. So this option was not discussed in an unmarried woman. It is not an option. But in which cases of fibroid uterus you can think about LNG, IUD? Yes?
If it is associated with adenomyosis, their LNGs work very, very good.
Even if it is not adenomyosis. Even in fibroid uterus, we can use smaller size. And yes, what you were saying?
Intramural.
Intramural. Okay. So how does
Because rate of expulsion is less in intramural.
In cases of leiomyoma, if you want to use LNG IUS, a lot of people have, reservation about the use. But the most important finding that should be absolutely clear about is whether the cavity and the other things are not distorted.
Exactly.
So
This
very
you need
important
to
finding.
be saying.
Unless and until you are sure about the normal cavity, it's not distorted, you should not use this LNG IUS in
Because
fibroid.
if it is distorted, you might as well perforate the uterus instead of doing any good, doing harm.
Good.
Okay,
Expulsion.
what about UAE? Uterine artery embolization, anything about that?
Yes, ma'am. We can go for uterine artery
So
embolization.
how do you select patients for UAE? What are the right candidates?
Ma'am, it affects in fertility. So patient family should be complete before going to uterine artery embolization. We should ask.
But then why
the-
not wait. But if family is complete, then let us not think about that, because then we have other options as well. Why do we use UAE? Why embolization? Why not then myomectomy or hysterectomy? There is some particular
It's
class.
no.
Suppose surgeries are contraindicated. There is a class of patients in which surgeries could be contraindicated, and at the same time, the size of the uterus and the bleeding is so much that something needs to be done, and medical management or everything has failed. So you can try that, right? Okay, so what are the prerequisites for that? What मतलब कुछ उसका है? Like suppose if it is this big, 26 weeks, can that be an option? No. So what patients are the right candidate for uterine artery embolization? One is you have to preserve uterus is preserved, not for fertility definitely, or some whatever reasons. What else?
Size of the uterus, ma'am.
Kitna size?
12 weeks.
12 weeks. Okay, arbitrary. ये पता है 12 weeks. Suppose it is one fibroid and suppose there are multiple fibroids. Which is a better patient for UAE?
One fibroid.
One fibroid. Okay. And what about MRFUS? MR guided focused ultrasound surgery. That again is a recent modality of treatment for fibroid uterus, right? Uske
Yes,
liye
ma'am.
yeah, what say?
So yes, where we have the facility of an interventional radiologist, then we can think about this embolization. It's a good method of treatment. But unfortunately, most of the centers in our country.
But when these girls are going to practice, I think Dr. I mean, this will be a better. More and more places will have the facility.
I know, actually, we were told this when we were studying also. That hasn't happened.
There are a lot of limitations with MRI focused ultrasound.
Yes.
Fibroid should not be more than 10 centimeters size. The distance between fat and
Yes.
fibroid should not
So
be more
if
than
the
12
patient is
centimeters.
obese
So
and
many things.
yeah, if it is posterior fibroid, again that's a problem.
Just focus on the.
No, I just want to add here. See, MR HIFU was earlier being used, and it has not received so much attention because of the problems it has. But now ultrasound guided HIFU is also there. And it is expanding like anything. If you see, the centers are expanding with the ultrasound guided HIFU, although not in India, in Asian countries, and now it has come in Oxford and other countries also. Ultrasound HIFU is better than MR HIFU. So the students can.
How the MR got promoted. I had always thought that, but then the MR got promoted. And in the beginning, when we were hearing about the HIFU, the people always used to say something like MRI is mandatory. It should not be.
Yeah.
Right? It should not be.
That is what I'm saying. For ultrasound HIFU, MRI is not mandatory simultaneously. So that is what the advantage of ultrasound HIFU, and you can do it with our ultrasound machine. Like we are having ultrasound machine, in the same ultrasound sitting, we can have HIFU, although it is a different machine, but it is similar to ultrasound. So ultrasound hypo is having lot many advantages. Though, so one can go and read the differences and the advantages.
I mean, resolution. You are getting any benefit in the procedure, or it is just another option?
No, it is better in the sense that see, MR is not available everywhere, and you cannot have the MR at the real time. Ultrasound is giving you the real time actually. So MR images, if it has been done earlier, those are translated into ultrasound images, and the real time ultrasound, and those images are coordinated to get the exact location to target the rays. So that way you destroy the fibroid. So there are studies and there are lot many things which are coming up, although it is a Chinese technology, but people are coming with lot, and Oxford recently has installed these. So it has come in Oxford, and lot many studies are coming up nowadays. So I feel ultrasound is better because MR has its limitations. So that is why it was not has come into much recognition by all of us. Like in India, 2 centers have started with hypo MR, but they were not very popular. And somehow they went into nobody is now recommending. But ultrasound guided hypo is coming up nowadays. Although in India there is no such machine, but yes, in the other countries it is coming up like anything.
We need to
So as compared to ultrasound, the MR is costing more also.
Yeah.
Yes, obviously.
At another fact.
Cost is another factor. Besides, there is some concept which came in the middle, MR guided ultrasound. That also we have heard. And so what happens that our own traditional surgical management is good enough. And
just to complete the list, Dr. Preeti, do you have any idea about the progesterone receptor modulators or estrogen receptor modulators? Any effect on fibroid uterus?
No, we have discussed that. We have
The progesterone receptors, I don't think we discussed.
Yeah, we discussed.
No, Dr. Ashish, I think we should ask the student. See, we have now different options. We have the option of total abdominal hysterectomy. We have option of LABH. We have option of TLH, and we have option of NDVH. So the student should be very clear what all be done and what are the advantages, disadvantages of each approach, and when to go for which one. So if they can answer some of them, it will be better.
To know about the vaginal morcellation, which is coming up procedure, because as the abdominal morcellation is being discarded, now the vaginal morcellation is coming into play. So they should know about that. So students, can you tell us about the which way do you like to go? It's an LAVH or an NDVH? Now different setup.
And we have to see 5 minutes. We have 5 minutes.
4 minutes, not even 5 minutes. So
we'll wind up then.
In different setups, we have different sets of surgeons. NDVH is a very, very effective method, but then you need to have a very good surgeon and a very good surgical team. And on the other hand, LAVH is also equally effective, but you need to have a good laparoscopic team with that. So according to your setup, you can answer in the question examination like that. So I will take input from Dr. Hemkanta Sharma, and then I'll close. We have only 3 minutes.
I have one question to Preeti. So what is your comment on malignancy? Suppose you have removed one, you've done a myomectomy, and after that your report comes something else. It comes like somebody says that there is something like malignancy. And what is the incidence and what will do next? Preeti.
So
what is the incidence of malignancy?
Incidence is very less than 0.2 to 0.5%.
1 in 1,000 to 2,000, isn't it? Something like that. So not very common, but it is serious. If somebody is suffering from that, it is very serious because malignancy is a leiomyosarcoma which spreads very fast. Prognosis is not good. So what you do? So in that case, suppose a myomectomy was done and you find a report of leiomyosarcoma.
So then we'll go for radical hysterectomy.
No. I think the hysterectomy is already done, right? Or
yes.
No, it was myomectomy.
Myomectomy has
Okay, that's just common one. So there are some cases we have seen that they say that it is something like sarcoma. It is not 100%. So in between, can you say that what are the diagnostic point? If there is a leiomyosarcoma, what are things you will get?
Yes, sir. Sudden increase in size and bleeding and pain. Basically, suddenly there will be increase in size.
Clinically, there will be fast increase in size, isn't it? Fast. So how do you say it is fast? Can you tell me the normal increase of size? How fast it is going? Say 2 centimeter fibroid will become 4 centimeter. When? How long it will take?
Sir, more than 8 week increase in size in 1 month, sir.
Actually, it is said that it is around 89% increase in size in 18 months. Suppose a 2 centimeter size of fibroid will become 4 centimeter, say after 4 to 5 years. So it goes very slowly. Okay. But if something comes very fast, say 20-week size becomes 26-week size within 1 year. So that is 6-week size has increased very fast. So it is a fast one. Another one is bleeding is okay. And there might be pain along with that. Pain and tenderness. Okay. So these are clinical and suspicious. So if you have done a myomectomy and after that the report comes something in between. So there is a group of patients where we call it, there is suspicious cases. These are not 100%, but suspicious. So there are mitotic figures. That means if the mitotic figures are more than 10, or 10 high power field, so it is always a suspicious one. Okay, yes. So it may be a sarcoma. That it should be reviewed. This slide should be reviewed. Okay. Yeah. Another one, it is there should be there are some cytological abnormalities. Okay.
Yes,
and there is some amount of necrosis. So if the histology comes like that, so it is a suspicious case, and it is something so that in between. It is of if it is less than 10 mitotic figure, then it is in between. It is not 100% sarcoma. So this slide should be reviewed. So they will have to review the block by an expert histopathologist, right? So after that you go accordingly. Yes. So the sarcoma is, and another thing is that clinically, when you get a patient first, before while you are assessing, one thing is clinically you say it is fast increasing, pain is there, tenderness is there, bleeding is there. Okay. But at the same time, you can see something else. The one thing is LDH. So that level will go very high. Okay, total LDH will be very high. Another one is ISO. There is another ISO LDH is there. Okay, that one will be present and high. Another one is the MRI. There is nowadays there is MRI. Okay, what type of MRI? That is called dynamic MRI. So there is a modified MRI. So that will detect that is a patient of fibrosarcoma. Okay, so you can diagnose like that. Though it is very uncommon, but it is very unfortunate for the patient. Though it is rare, so you should be careful in that line also, right? Okay.
Thank you, Dr. Hemkankar, for those closing remarks. And I would like to take 2 quick comments from the people who haven't spoken a word also so far. That is Dr. Sangeeta Rai, one, and one is Dr. Hafizur Rahman. And then I will leave it to Dr. Ashok Kumar for closing remarks and then close.
Thank you, respected teachers, and a very nice presentation from Preeti and Dr. Garima. Yes, we need to learn just second years because the third year examining us. So in this hectic period, they just prepared a nice presentation. So I'm thankful to both my students and all the chairpersons, Dr. Ashok Kumar sir and Madam Dr. Kodam, Dr. Agini ma'am for chairing the session. Thank you, everyone.
Thank you, Dr. Hafizur. Are you there? You are coming like intermittent showers. You're coming and going. Like to say something? Okay. Then I will request Dr. Ashok Kumar to remarks. Yes.
Sir, Ashish sir, I'm sorry. Actually, I don't have even electricity also. Okay. I'm just relying on mobile network. It's coming and going in every 5 minutes and 10 minutes.
Okay. You're running on batteries now.
Yes, sir. Ashok sir. Yeah.
Yeah, so I think this was a very useful and informative discussion we had on fibroid uterus. And I thank all of you for your participation and sparing your valuable time today, Sunday in the morning. And I am thankful to Dr. Habibullah sir and our all other faculty Dr. Sheila Madam, Dr. Hemkant Sharma, Dr. Poonam Mathur, and Dr. Nalini Anand. And again, I am also thankful to Dr. Sangeeta Rai and Dr. Shaila Jamal for coordinating the case presentation with their students. And again, I will not forget Dr. Ashish Mukhopadhyay and Dr. Hafizur Rahman for helping ICOG for this activity. Thank you very much all, and all the very best to all of you. I hope in this month and in next month, some of the students will be having their final exam. So all the best for that examination also. Thank you very much. We'll see you again in next month, second Sunday of the month with another topic. And just to remind you once again that all these, the recording of all these are available on the ICOG website. You can refer to them anytime and just get the benefit from those recordings. Yes, Dr. Hafiz?
I just want to
Yes,
say,
yes.
because many of the colleges would like to present. So any students, because I have been told that so we don't give many of the colleges and opportunities like that. Main part is we are not able to know who are interested. So if the colleges they themselves are, we would like to take representation from the different parts also, so that we can include them also. It is not like that we are selecting on a particular basis from this college. We would like to take
I just want to make it clear, as in the beginning also I told, we want to reach every corner of the country, and we want to involve as many as teachers, as many as students for this program. So purpose is that we should if you see our all programs on the website, we have teachers from different medical colleges and different parts of the country. So we try to involve each and everyone. Whoever is interested can tell us. We have no limitation on that.
Correct.
Yes, sir. We'll include them maybe on a rotation in a coming program. It is not like that we are purposely selecting some institution or some faculties.
No.
So anyone, those are interested, they just can contact us so that we can enroll them in future program. That's what I want to say, sir. And again, this is thank you for all the students. They have been fantastically well for their coordinating as well as the presentation. Thank you, Ashok sir and Ashish sir. Always they are in the backbone for the program. So we'll continue.
For the younger generation, because they are having more and more problems regarding handling the computer and the internet. More than at least they're not so young teachers. What I am finding is that they are getting more problems in the communication sector. So with that,
yes.
All right, bye-bye to all of you, and see you on 9th
Bye.
July.
Thank you.
We can, the host team can stop the recording now.
Yeah.
Yes, sir. Yes, sir.
Thank you. Thank you.
So thank you very much, sir. All everyone. Thank you very much.